online time. We'll start in 2 to 3 minutes.
Yeah. Obviously, you take the call.
Participants are joining. I'll have to operate the slides from my side, right?
Oh, okay. Can I operate myself also?
Yes, yes, you can.
You can.
You can share your screen, or you can just call out the next and I will move the slides. Whatever is
Okay. Okay.
So we'll just start with our sessions. Okay. So good morning, everyone. Welcome to the webinar organized by Elite Education and Welfare Society in association with the Indian Institute of Medical Science and Research, Padnapur, Jalna. I'm Dr. Zubair Khazi, Scientific Facilitator for today's webinar on cardio, kidney, and metabolic syndrome. And the observer for this webinar is Dr. Swapnil Bhagwan Das Mantri, will be the observer. I request all the delegates to kindly keep their audio on a mute mode, and attendance will be taken as the guidelines are already, published into the group. Attendance will be taken after the first session, and 2 hours after that, the, almost at the end of that we will this. Okay, ma'am. I request everyone to mute. Now I call up of Elite Education, Dr. Muhammad Shafi, for the
Very good morning to all of you. On Elite Education and Welfare Society, I welcome you all to this webinar on cardio, kidney, and metabolic syndrome. This is our 10th seminar from Elite CME Academy and Elite Education and Welfare Society in collaboration with AIIU's Indian Medical Science and Research, Badnapur, Jalna. We are very thankful to our institute, our founding chairman, I pray that Allah will grant highest place in the paradise. Our president of AIU, Maulana Huzaifa Wastani Sahab, CEO of Indian Institute of Medical Science and Research, Dr. Ilyas Behmat sir, our constant support and host these seminars and is Dr. Sahib Siddiqui of AIMSA and our elite welfare society, Dr. Zubair Khazi and Al Hashmi. I also welcome our MMC observer, Dr. Swapnil Mantri sir from Partur. He has joined. I am very thankful to all the speakers. Just by the message of WhatsApp, deliver the talk. I welcome all the speakers. I welcome all the delegates. I hope that the webinar is going to be an academic feast for all of you. And I'm very happy and glad to share that This webinar has become international because we have delegates from United Kingdom, Dr. Geet, I welcome you, and Dr. Sapna from Malaysia, and all other delegates from Maharashtra and all over India. So I am very thankful to all of you. I hope that you will stay with us, and webinar is going to be a academic feast for all of you. First time I heard about this cardio kidney metabolic syndrome. We used to hear about the metabolic syndrome, but we thought why not to have a webinar on cardio metabolic kidney metabolic syndrome. So today we have this webinar for you for great points. Uh, all the speakers are very expert in their field, and they have taken a lot of efforts to prepare and present. So I request all the delegates to be there with the Zoom meeting so that you will understand the topic in a nice manner. So once again, I would initiate the class. Thank you. Now we'll start the class. First we will with Dr. Geet Prasad sir. Request Dr. Ganesh Hazi to invite his delegates.
Thank you very much, sir. So for the first session in today's webinar, I call upon Dr. Yogesh Lakhas to deliver the talk on critical care in cardio, kidney, and metabolic syndrome. Sir is professor and ICU head at Indian Institute of Medical Science and Research, secretary of IMA Chhatrapati Sambhajinagar currently, and secretary for Indian Society of Critical Care Medicine for the term 2020. I request sir to start the talk and share the slide.
Okay. Can you please share the slide? Yeah. And could I operate from my end? Like even if it is shared from your side, or you will have to operate?
I will have to
Okay. Just a minute.
request the delegates to kindly mute.
Just a minute. I'm just. Dr. Zufar, please share from your side. We'll do that way. Okay.
Yes,
Yeah.
you
Yeah.
can tell so that I'll move.
Absolutely. Absolutely. We'll do that. Yeah. Yeah. The we'll go with the critical care in CKM syndrome. This is a very important this is very important syndrome. And first of all, I thank you, Shafi sir, for organizing such webinars on a frequent basis, and that is really helping out all residents, consultants, and everyone. And this is something very important. And he is fully supported by our management under Ilyas sir, then Dean Siddiqui sir, and we will go with the critical care in CKM syndrome. Please, next slide. Learning objectives for this syndrome. Everyone need to understand CKM syndrome and relevance in ICU. Recognize pathophysiological crosstalk, identify ICU presentations, apply integrated hemodynamic renal metabolic management. The integrated management is very important because that really makes the difference in outcome of the patient. Then discuss role of monitoring and future directions. Next slide. What is really the previous one? Mm, one yeah. What is CKM syndrome? CKM syndrome is a continuum of cardiovascular, kidney, and metabolic disease where dysfunction in one organ accelerates the failure of others. Because that multi-organ dysfunction that really matters, and when particularly it comes to the ICU setup, really every minute counts for outcome of that patient. And it is not a isolated organ failure. Obviously, each and every organ is dependent on the other organs to work in harmony, or we can say the homeostasis of the body is maintained that way. And it is a dynamic bidirectional interaction, like the cardiac that will interact with the kidneys will interact with the myocardium. Either it is a cardiorenal syndrome or it is a renocardial vice versa syndrome, and one has to be very vigilant while managing these syndromes. And common in ICU patients, particularly when we deal sepsis, when we are dealing the shock, when we are dealing with the heart failure, and in addition to that, the risk factors like diabetes is there already, hypertension is there. These are the all risk factors, and where we really come across this syndrome. Basically, it is a failure of main two systems like the heart and the kidneys, and along with the other metabolic factors, those play in the role. Next slide, please. Why CKM matters in the critical care? As the terminologies one can see, ICU patient often present with combined dysfunction, and whenever more than one organ is failed, definitely the mortality rises exponentially with multi-organ involvement. And traditional management may not be appropriate that way, and you may need the high-end hemodynamic monitors. You may need the to change the treatment which will affect your myocardial thing also, and you will have to interact with the kidneys also. And ultimately the integrated physiology based approach, that is very important for a base outcome of CKM syndrome. And you will have to be vigilant in ICU. You will have to monitor each and every parameter, each and every minute, each and every hour, each day will matter, because other things are also working simultaneously there, like sepsis may be there, and the organs may fail one by one, or simultaneously the patient may come to you with complete, like many organs fail simultaneously, and then really it is a very challenging situation for an intensivist. But the central role of ICU managing all these things, that is very important. Next slide, please. What are the stages of the CKM? As we discussed, risk factors: obesity, diabetes, hypertension. I'll add age also to that. That will matter a lot. Then stage one, it is a subclinical organ injury. That we may say that when metabolic syndrome is developing, or OPD patients, when we find a obese patient, then this patient is likely to develop a different acute decompensation during his 10 years of life, during his or her 20 years of life. One has to tackle, like always we say that prevention is better than cure. If we tackle that morbid obesity at early stage, we tackle the hypertension, we tackle the diabetes early, then definitely that will be the prevention for the decompensation of or acute care needed in the future life. Then established disease, heart failure may be there, heart failure with preserved ejection fraction may be there. Then patient may have gone into the CKD stage. Then diabetes mellitus you are managing simultaneously. Then the advanced disease, like patient is already on the dialysis and that way. And stage 4, this is the acute decompensation, which in this condition many patient comes to us. And then definitely there will come a ventilatory management. There will be a patient might be in shock that we have to manage. Then patient may come in acute renal decompensation or acute renal failure, that we will have to take the decision of whether this would be managed conservatively, or will this be need a CRRT, continuous renal replacement therapy. So that's why these four stages are very important. Next slide, please. Next slide. Yeah. Pathophysiology. Understanding the pathophysiology is very important. Previous one. Uh, Previous one. Two slides are there regarding the pathophysiology. Yes. Cardiorenal axis that plays a crucial role. Reduced cardiac output leads to the renal hyperperfusion, and that leads to the failure of the renal system. Then, in addition to that, there can be a reverse pressure changes that can lead to venous congestion, and that can be part of the congestive AKI. And RAS system is very important because to maintain the homeostasis, it will try to accumulate the fluid. Then that can be the fluid overload can be there. Then sympathetic nervous system, it is activated to overcome the cardiac failure. But later on, it can have the deleterious effects on the body, and that can even lead to the cardiac arrest, and that's the all these sorts of things. So each and every compensatory mechanism you have to understand while understanding the cardiorenal syndrome or the CKM syndrome. Then inflammation is already there. Endothelial dysfunction is there, like in a case of sepsis, in a case of viral sepsis, we can say. And this cardiorenal syndrome, the different stages we have discussed. Next slide, please. In continuation with the previous slide, the metabolic syndrome that drives it. Like what comes under that? The insulin resistance is there. The hyperglycemia induced oxidative stress would be there. Even in the sepsis, we can see that stress hyperglycemia is there. That can be the deleterious for the homeostasis in the body. Then that obese patient, that lipotoxicity would be there, and chronic inflammation is always there in all these patients. That's why we have seen in the many trials that even reduction of 5 to 7 kg of the weight in preventive stage of the morbid obesity, that changes the life of those patients significantly. And metabolic disease amplifies both cardiac and renal injury. Definitely all these metabolic parameters, that will be the add-on, you can say risk factors, or that will be the additive to the decompensation that has happened to the myocardium or the renal system. Next slide, please. And what are the common ICU presentation of CKM? Well, we can see that septic shock patient comes and that develops AKI, and stress hyperglycemia can be there. There are the challenges of managing that sepsis. You have to choose the appropriate antibiotic. Then you have to know the local antibiogram of your institute, because many of these are the gram negative infection, MDR infections we always deal in the ICU. And simultaneously many of the antibiotics, they may be nephrotoxics, so you have to take care of with appropriate doses of the antibiotic you will be giving, so that additional renal injury doesn't happen. But simultaneously you have the challenge of giving the appropriate dose also. That's why the main condition is always we don't reduce the loading dose. We have to know the pharmacokinetic of many drugs. Like many drugs are time dependence, many drugs are concentration dependence, that one has to know, so that you will be changing or you will be adjusting the doses that way. So that pharmacokinetic, it is all antibiotic stewardship that we have to follow for the better outcome, and to prevent the damage caused by these nephrotoxic agents, and that can be the add-on for the detrimental effect or outcome of that patient. Simultaneously we can see that acute decompensated heart failure, that can lead to the AKI. like patient where the acute accelerated hypertension comes and that leads to the acute heart failure. The shock is there, cardiogenic shock is there. You are differentiating it clinically and based on other parameters, and definitely that hypoperfusion will lead to the additional kidney injury, and that can lead to acute renal failure. There can be complete anuria. You may need the urgent renal replacement therapy, and simultaneously you have to manage the cardiogenic shock. That can be post myocardial infarction also, and that way. Diabetic patients with shock and worsening renal function. We have seen that clinically that many diabetic patients they will be prone for this, and gradually or even acute decompensation occurs in diabetic patients regarding the renal functions. As we can see that uh, myocardium and the renal, these are the important two systems to maintain the perfusion of the body, and these two systems play a very crucial role for maintenance of the perfusion to each and every organ. Then there can be decompensation that is leading to renal injury after the cardiac surgery, and this cardiorenal syndrome with metabolic derangements is usually there. Next slide, please. Now, as we discussed, hemodynamic challenges are always there in the cardiac, kidney, and metabolic syndrome, because narrow therapeutic index, as we discussed, that we have to know the pharmacokinetics of drugs also, then pharmacodynamic of drug also. That like even in the, let's say, like if you are needing the antifungals in some of the fungal sepsis or that way, they do have very narrow therapeutic index as compared to the antibiotic. Then that every aspect you have to know. Then one side is fluid overload and other side is hypoperfusion. So appropriate individualized approach that matters. You have to consider each and every patient differently. You have to give fluid simultaneously, but more restriction that can lead to hypoperfusion, and again that can lead to the renal failure. Or other way around, you may give the more fluid, there would be the fluid overload, and that can lead to the congestive nephropathy or load on the heart, and heart can failure. So this is a like crucial aspects of fluid challenge. Then always we say in the ICU that 30 ml per kg or that way, never treat the figures. Your clinical judgment is a very important while judging the fluid, or while giving the fluid to the patients. And there are different fluids you have to know, like plasma light is there, normal saline is there, ringer lactate is there. And what is the importance, how one fluid is superior to the other, at every aspect one has to know while managing these hemodynamic challenges. Then vasopressors play crucial role in any shock. The As we say that noradrenaline is the first vasopressor of choice, then as trials have proven that after noradrenaline we go with the vasopressin. Then there can be additional like dobutamine we may be adding when cardiac dysfunction is there. And you have to maintain the MAP, that mean arterial pressure targets, and it has to be individualized. The one map, like one side fits for all, that can be dangerous. So it has to be always individualized. You will be taking the help of the gadgets like hemodynamic advanced hemodynamic monitors and all those, but your clinical judgment is ultimately going to play important role. And there can be the refractory shock also, you might need to tackle that. And your vigilance on that particular patient each and every minute is going to count. Next slide, please. As we discussed, fluid management is again the important. Avoid blind fluid boluses. Reassess the parameters like fluid responsiveness is there or not. Because if various dynamic parameters, static parameters like CVP, they might not be that useful, or that might not give you the exact situation. Then dynamic parameters are there, pulse pressure variation is there, stroke volume variation is there. You can serial with the now focus is into the ICU field. You can go for the IVC diameter, and that way. Then you can go for the cardiac index also. Various monitors are giving you the different parameters. Then advanced hemodynamic monitors are there. Those also give you the certain parameters, and that may be helpful to you for fluid management strategy. And early resuscitation, that is also important. whenever you give the fluid to any patients, you have to, maybe on the second day, maybe on the third day, you have to have mind in that ki I might need to de-resuscitate with fluid. That may be with diuretics, or that maybe with the renal replacement therapy. When a congestive AKI dominates, you may need the CRRT. Next slide, please. Vasopressors, yeah, vasopressors. We discussed that norepinephrine is the first choice. Then avoid excessive vasoconstriction, because that again can lead to the hypoperfusion. That again can lead to the worsening of the failure of the organ. In low output states, whenever myocardial dysfunction you are suspecting clinically and you are judging that with the 2D echo that is used routinely in the ICU nowadays in all the setups, dobutamine, milrinone cautiously can be used. Milrinone, in the trials, milrinone has been found to be more efficacious only in post cardiac surgery, but otherwise both agents are the of same efficacy. Then balanced renal perfusion versus the afterload that we saw, we have to simultaneously manage that perfusion happens, and simultaneously after like overload is not there, that always we have to manage. Next slide, please. Renal management in the CK. Early AKI detection. Always the any parameter you are using, it is always a trend based. Like if you follow the procalcitonin, then also a trend you have to see. If you follow the lactate in the ICU, then again the trend will matter. A single figure, single investigation report is not going to give you. And in addition to that, you will have to have the clinical judgment at particular that time, and that decision, your intensive decision, that will matter a lot. Then avoid nephrotoxins, adjust the dose drugs dynamically. The whole situation is dynamic. At every time you will be changing. One has to change the approach towards the patient. Either you will be escalating or you will be de-escalating that way. Then CRR, what are the CRRT indications? As we discussed, fluid overload is there, refractory acidosis is there, hyperkalemia is there, then uremic complications, and that appropriate time for starting CRT, that matters, because delay in CRT again, that is going to lead to increased mortality in the patients. Next slide, please. Glycemic control, as we have seen, diabetes is very important, like risk factors as well as, and that can lead to oxidative stress. Hyperglycemia always we observe in the ICU patients, and that worsens the outcome. Target blood sugar is 140 to 180. But simultaneously avoid the hypoglycemia, because many of the trials they have found that the tight control of sugars, that has led to the worse outcome. Slight deviation can be there. Then continuous insulin infusion with close monitoring, that may be needed in some of the patients. But the target 140 to 180, one has to keep in mind, or that way, and that very important for the in sepsis also, and in every ICU patients. Next slide, please. Biomarkers, as we and monitoring. We have many like gadgets also and biomarkers also. Then lactate trends, always rely on the trends, not a single value that you will be relying, or you will not be taking your judgment with a single value. Then urine output, that whenever urine output is there, that itself shows that you are on the right track and your kidney is perfusing very well. And at that time, you may be, once it starts, then you may be starting de-resuscitation, or like you will be restricting the fluid, and then if needed you may be adding diuretics, or you may take help of the CRRT. Then creatinine, as we see that that reflects a previous injury. Means like whenever urine output starts and your creatinine is still raised, but you need to tackle a sepsis, you need to increase the dose of antibiotic, or say creatinine will be dropping later on. Like your output will start earlier, and creatinine you may next day or next to next day, that will be coming down. So falsely judgment should not be taken. Then fluid balance is a trajectory. Then bedside echo and lung ultrasound, that is a core part of ICU now, as a point of care ultrasound we all use in the ICU. Next slide, please. Now AI is coming a strong way, and what AI is going to help us. early AKI risk prediction would be there. Then fluid overload phenotyping that we can assess. Then nephrotoxin burden. But what input we give to AI, certain things will depend. That appropriate input will lead to the appropriate alerts. Now whatever softwares are there or that way, almost two alarms will be false out of the three alarms. So picking the right alarm and using that and making the clinical judgment for that, that will really make the change in outcome of the patient. AI assists it, it will not replace the clinical judgment of a clinician. Next slide please. And this is one of the important slide. So what are the pitfalls in the CKM in ICU care? Over resuscitation with the fluid, that can be dangerous. Then late recognition of congestive AKI, like even if that 1 day delay or few hours of delay, that may change the outcome of the patient. You had to start the CRRT at that time. That appropriate timing matters a lot. Then ignoring the metabolic contributors, like you have to simultaneously manage the like sugar levels. Then delayed renal replacement therapy, again that can have the delayed risk or bad outcome for that patient. And what we see commonly in the current practice, fragmented specialty driven decisions. That's why a closed ICU matters a lot. A ICU in charge has to be there, who will be taking complete decision for that. You can have the subspecialty opinions, but otherwise if multiple opinions are there when one single fellow is not monitoring the all detailed parameters, then opinion can be fragmented. Like your resident will judge in or he will just follow the orders. He will start with one specialty, then second specialty, then third specialty, and there can be a bad outcome for that patient. That's why multiple specialties you will have to have the always interaction while managing a critical care patients, while managing the CKM syndrome particularly. Next slide please. This is a just a case scenario, like 65-year-old diabetic with sepsis presented in the shock. As we started with the noradrenaline, we have also given fluid always we have to give, but with the clinical judgment. Then rising creatinine is there, then positive fluid balance is there, and hyperglycemia is there. This is the case scenario. What will be the integrated approach? Early vasopressors, depending once the fluid resuscitation is done. Then as there is a positive fluid balance, conservative fluids, you will be going for the restrictive strategy. Then glycemic control you will be doing, and you will be avoiding the nephrotoxin. That will be the integrated approach in these patients. And as we have seen that for the MBBS students also, now NMC has recommended integrated approach. Like they are exposed to the clinical things earlier, right from the first year of their MBBS curriculum. That's why integrated approach is very important in all the critical care patients, all CKM syndromes, and that will change the outcome of the patient. Next slide, please. And this is second last slide, or key take home messages. CKM syndrome is very common. You have to be vigilant. Organ fail together. No, or they do not fail alone. Always after one organ, you have to be cautious about the next organ. Then management has to be integrated. The trend has to be observed in the ICU, like lactate trends. Not don't give a much value, and your clinical judgment has to be based on the trend. Then everything you have to bring back the physiology normal, and that will save kidney, heart, and other organs also. And future ICU care will be CKM based. This line itself denotes that CKM is a very important syndrome in the critical care, and one has to focus on that for a good outcome. Next slide, please. In critical care, treating heart, kidney, or glucose alone is incomplete. CKM syndrome demands the integrated thinking. Thank you. Thank you very much. Thank you, Shafi sir. And this is all from my side. If any question is there. or itself. Hope I delivered it concisely for all the critical care specialists, all residents they might have joined, and this is a very important while managing any critically ill patients. Integrated approach, that message I would like to give to each and every one of you. Thank you very much.
Thank you very much, sir. Indeed, of knowledge session and the pitfalls that you have linked down. That, thank you very much.
Thank you.
Uh,
Yeah.
we will just go with the first segment, which was on the delegate. So kindly keep their cameras on, but keep your mic. Take I have to say key for everyone. See one of my batchmates Glory, who has joined. I joined.
Hey, आपको पता बा काय झालं ते इतने काही विकास काम करायला लागते नाही सांगा ना तरुण यांना सांगा आपल्या ऑफिसमध्ये लागतो कोणी आल्यावर सरसमध्ये ऑफिसमध्ये देऊन टाकतो माझी एकटी
Question. Thank you. So, deliver our next talk, fundamentals of cardio, kidney, and metabolic syndrome. So we have Suhail Noorani, who is assistant professor in medicine at Indian Institute of Medical Sciences. Sir, sir, you are there available. You can ask. Yes, sir.
Okay, thank you, sir. Am I audible?
Yes, you are audible.
Just a minute, I will share my screen. Sir, is the slideshow? Okay.
Yes.
Okay, thank you, sir. So, good morning, everyone. Myself, Dr. Sohail Noorani, assistant professor in Department of Medicine. So, before starting the lecture, I would like to thank all of the organizing committee and team of Elite Academy, for giving me this opportunity to deliver this lecture. So topic for today's lecture is fundamentals of cardiovascular kidney metabolic syndrome. As we all know, we had this concept of metabolic syndrome in which we had few key components like obesity, hypertension, diabetes, and cholesterol imbalance or lipid imbalance. Then the American Heart Society, they integrated this metabolic syndrome with this cardiovascular and kidney, these two organs, to give this cardiovascular kidney metabolic syndrome. And the main aim of integrating this cardiovascular kidney metabolic syndrome was to give a holistic approach for diseases of cardiovascular system and kidney diseases. Because whenever a patient presents with some cardiovascular problem, he mostly has associated problems in kidney or other organs. And the root cause for these problems is a metabolic syndrome, which can be either insulin resistance or something, which we will see further in our pathophysiology. So rather than treating each and every problem individually, the main aim of giving this CKM syndrome approach was that we can treat the problem on the basis of its pathophysiology. So that's why they have integrated all these things. So first of all, how do they define this CKM syndrome? The American Heart Association has defined the CKM syndrome as a systematic disorder characterized by pathophysiological interactions among the metabolic risk factors. Now, these metabolic risk factors are generally obesity, insulin resistance, and lipid derangement. So, pathophysiological interactions among these metabolic risk factors, the chronic kidney disease, and the cardiovascular system. So, it is an interaction between all these three things. Metabolic risk factors are present. How do they affect the kidney as well as the cardiovascular system? And further, not only these two organs, but it can lead to multi-organ dysfunction. It can lead to even liver failure. It can lead to even hemodynamic imbalances. It can even lead to neurological problems that we will see in complications. There are some neurological problems which are attributed to this metabolic syndrome or the metabolic risk factors, and very high rate of adverse cardiovascular outcomes. So this is the definition of CKM syndrome. Now, how all this started, where this very concept of CKM syndrome arose from. So going to this background, we had this earlier metabolic syndrome, which we all might have studied in our UG or PG days or some recently. So metabolic syndrome is a multifactorial disease with insulin resistance as a key pathophysiological driver. So the main mechanism or the main culprit for metabolic syndrome was considered as insulin resistance. But now theories have more developed. Insulin resistance itself is considered because of obesity. So this is now the, at present, this is the scenario. So metabolic syndrome, exactly what is metabolic syndrome? There are 5 main components in metabolic syndrome, out of which one is the waist circumference, more than 40 inches in men and more than 35 inches in women. Along with that, high blood pressure, then impaired glucose levels or deranged glucose levels, for which we consider fasting blood glucose more than 100 mg. And then along with that, low HDL cholesterol and high triglyceride levels. So these are the 5 components, out of which for diagnosis of metabolic syndrome, 3 or more, at least 3 should be present to label the person as diagnosed metabolic syndrome. Again here, few things. Fasting glucose more than 100 milligram per deciliter, or patient is receiving drug therapy for hyperglycemia. Similarly, blood pressure more than 135 by 80, more than 130 by 85, or patient is receiving drug therapy for the same. Triglycerides more than 150, or patient is receiving drug therapy for it. Then HDL cholesterol less than 40 in men, less than 50 in women, or patient is receiving drug therapy for the same. And lastly, for waist circumference, even though the main guidelines say it is 40 inches for men and 35 inches for women, for Asian population, since they have a different genetic makeup and they are more prone for developing any kind of metabolic disease, be it diabetes or be it even metabolic associated steatohepatitis, what we earlier used to call it as NASH. non-alcoholic steatohepatitis, non-alcoholic fatty liver disease. So Asian population are more prone. And even in alcoholics, we see that alcoholic liver disease develops in Asian at a very less threshold. So waist circumference for Asian, it is different. It is 90 centimeters in men, 80 centimeters in women, different from the Western population. So this is the metabolic syndrome. Any three of these criteria are present, we will label the person as a metabolic syndrome. Now, what the American Heart Association did in 2023, it categorized this metabolic syndrome as a stage of a larger cardiovascular kidney metabolic syndrome. So it integrated this and it considered this metabolic syndrome as a stage of this cardiovascular kidney metabolic syndrome. We have various stages. There are 5 stages in CKM syndrome that sir will be discussing in the next lecture. So now what happens is, now we get to know the person who are at risk for developing any cardiovascular event or any chronic kidney disease or kidney failure because of this metabolic cause. So these are the risk factors basically, and we will get to know the person who are prone or more likely to develop these complications at a later stage. So these are the 5 stages. I will not be discussing this in detail as we have a separate lecture for this. When no risk factor is present at stage 0, just presence of excess adiposity or a dysfunctional adiposity, which I was telling now, this is the main culprit, or this is considered now as the main culprit as per the present theories. Excess or dysfunctional adipose tissue. So that is stage 1. Just means just presence of obesity itself is a takes the patient into a stage of CKM syndrome, because this is where everything starts. Then metabolic risk factors are present. Here metabolic risk factors means patient is having deranged sugar levels, patient is having deranged lipid profile. So this is a metabolic risk factors, or signs of insulin resistance. Not even this, just signs of insulin resistance also is a metabolic risk factors. And along with that, either patient is having moderate to high risk CKD. So that will come in stage 2. Stage 3 is having, person is having a subclinical cardiovascular disease. So that comes under stage 3. Subclinical means the patient is not showing symptoms of that, but patient is having atherosclerosis, patient is having lesion or some sort of cardiovascular disease overlapping with these metabolic risk factors. So that comes under stage 3. And when the cardiovascular disease becomes clinical, that becomes stage 4. Again, stage 4 is divided into stage 4A, 4B. So I'm not going into details of that. Now, this is the recent change that they have done to this metabolic syndrome. In 2025, just last year, the European Atherosclerosis Society, they again reconceptualized metabolic syndrome as systematic metabolic disorder. And they defined this as a cluster of metabolic abnormalities affecting multiple organs, leading to increased morbidity and mortality from both cardiovascular as well as non-cardiovascular causes. Again, the basis for this classification or developing this definition was it is not just the heart and kidneys that are affected by metabolic risk factors. The metabolic disease or metabolic syndrome, it can affect literally any organ. And most common example is the metabolic associated steatohepatitis, which we earlier used to call it as non-alcoholic steatohepatitis, NASH. So studies have shown, and even books, literature have mentioned it, that NASH is one of the leading causes of liver failure, especially in Western countries. So this is now a growing cause. Earlier it was alcohol use, and alcohol was the culprit, and alcohol was responsible for majority of cases of liver failure, cirrhosis. But now this non-alcoholic disease, which we now call as metabolic associated liver diseases, so this is growing in number. So we need to consider all organs of the body in total, all organ systems in total. So that's why they have rephrased this as systematic metabolic disorders, where metabolic abnormalities, they affect almost every organ or multiple organs at a time. So when there is a multiple organ failure because of some metabolic cause, we need to look at that root cause, and we need to direct our therapies towards that cause. So this was the main reason for developing this. And again, for that systematic metabolic disorder, they have again made stages, and there are 3 stages. Basically, it is, first is the metabolic abnormalities without organ damage. So patient is just having insulin resistance or obesity or liver steatosis, hypertension, dyslipidemia. So these are all metabolic abnormalities, but there is no organ damage. Then in stage 2, it will be some early organ damage. Type 2 diabetes, they have considered it as an early organ damage. So they have, means the patient has developed type 2 diabetes, so they have considered it as stage 2 patient. Again, metabolic associated steatohepatitis, CKD stage 3, subclinical cardiovascular disease or atherosclerotic cardiovascular disease, that is stage 2. And in stage 3, it is advanced organ damage. So heart failure, cirrhosis of liver, end stage renal disease. So these are all considered as stage 3, advanced organ damage. So these are the stages of systematic metabolic disorder. So risk factors for this cardiovascular kidney metabolic syndrome. There are various risk factors which are enlisted here. One important thing is family history. This is very important because of this person having family history of CKM syndrome or family history of some metabolic disorder. That person is more likely and he has more chances of developing this metabolic diseases and other associated organ failure. So that person should be very frequently, he should be screened for development of metabolic risk factors and CKM syndrome. Means a person who is not having any risk factor, but he is having family history for this metabolic diseases, he should be screened very frequently. What literature says, the American Heart Association has given a guideline that any child who is having a family history of metabolic disorder should be started with screening at 2 years of age. This is what the guidelines say. Right from 2 years of his age, he should be screened for development of metabolic risk factors. Even he doesn't have any risk factors, but he should be screened for development of those risk factors. So this is what we call in PSMS primordial prevention. So this is what the guidelines also recommend. And for those who don't have any family history, they should also be screened at least every 4 years of age, every 4 years gap. They should be screened for development of risk factors. Then again, poor diet, inadequate exercise. These are all the things which ultimately lead to obesity. Obesity leads to insulin resistance and type 2 diabetes. Then again, chronic inflammatory conditions like rheumatoid arthritis, lupus, or any other diseases, which is a chronic inflammatory condition. It is also a risk factor for CKM syndrome. Why? Because in pathophysiology, we will see that adipose tissue, how it exactly causes all these things is that this excess adipose tissue or the dysfunctional adipose tissue, they release pro-inflammatory and pro-oxidative reagents. And this reactive species, they are responsible for endothelial damage and then causing all this vascular damage. So again, chronic inflammatory conditions, they also have the same thing. That is, they also release the pro-inflammatory cytokines. And then again, that can cause the same chain of events. Then sleep disorders, elevated CRP, which is again an inflammatory marker. Genetics, again, depression or anxiety. And in females, these are some few risk factors: premature menopause, adverse pregnancy outcomes, and polycystic ovarian syndrome. And for men, erectile dysfunction. So these are the some of the risk factors for CKM syndrome. I think sir is going to cover this in his lecture also. And again, what the AHA has concluded in its guidelines, these risk factors develop because of these things. That is increased availability and consumption of high calorie and low fiber fast foods, then decreased physical activity, sedentary lifestyle, mechanized transportation. So basically, these are the things which lead to obesity. Obesity leads to insulin resistance. Insulin resistance leads to type 2 diabetes, and so on the chain of events go. So this social determinants of health, basically what are the social determinants in this CKM syndrome? So the AHA has divided it into 3 basic domains. One is the individual domain, in which the race, ethnicity, and sex of the person, his language literacy, educational attainment, health literacy, dietary quality, health insurance, all these things come. The second domain is the interpersonal domain, the social connection, interpersonal discrimination, disparate healthcare qualities, and psychosocial stress. And third is the community level domain, racial segregation, housing quality, civic participation, community level education, and then transportation access, all these things, they come under community level domain. So these are all the things, social determinants which affect the outcomes of this patient. So now coming to the most important part for today's lecture. This is the pathophysiology of the CKM syndrome. How exactly CKM syndrome develops and from where does it start? Understanding pathophysiology is important to direct our therapies towards that. Now, or till before that, what we used to do was, whatever the organ has suffered damage, we used to try to control that damage, or we used to treat the symptoms of that organ failure. But now we have therapies which target the root cause for this CKM syndrome, and the root cause is this excess adipose tissue. So this is the I am using this pointer here. The excess or the dysfunctional adipose tissue. This is the root cause for development of all the metabolic diseases, the problems associated with this, and further the organ damage. So excess adipose tissue or the centripetal obesity, this is now considered to be the root cause for all these things. Now, what does this do? It initiates an event of inflammation and oxidative stress in the body, and along with that, that causes insulin resistance. So how does it do? CKM syndrome most commonly originates from excess or dysfunctional adipose tissue. Now, this dysfunctional adipose tissue, particularly the visceral adipose tissue, it secretes the pro-inflammatory and pro-oxidative products. And what does this pro-inflammatory products do? They damage the arterial, cardiac, and kidney tissues. Mainly, they damage the endothelium of the blood vessels, and whereby the endothelial damage is the starting point for development of atherosclerosis and its events. That endothelial damage, there will be then aggregation of platelets over there. There will be formation of plaques. Along with that, lipid deposition will be there. There will be formation of plaque, and that will lead to formation of atheroma. So this is the starting point, endothelial damage, and that endothelial damage is triggered by this inflammatory products released by this dysfunctional adipose tissue. Again, what does this inflammatory process do? They also reduce the sensitivity to the action of insulin, and that causes insulin resistance, and then finally impaired glucose tolerance. Again, important point for development of MASH, or the metabolic associated steatohepatitis. So basically, there are two things in that. One is the excess of fat or the triglycerides. They deposit within the hepatocytes. This gives rise to steatosis. And secondly, the metabolic byproducts of the triglyceride. Triglyceride itself is not toxic, but the metabolic byproducts of the triglycerides, they cause lipotoxicity and they damage the hepatocytes, giving rise to hepato or the steatohepatitis. So there is steatosis, accumulation of fat, as well as inflammation within the liver, giving rise to steatohepatitis. And finally, the wound repair process of the liver starts, and then finally the liver goes into fibrosis and cirrhosis. Now, when this inflammatory or the pro-oxidative mediators, they are released into the systemic circulation, they exacerbate the pathophysiological processes involved in atherosclerosis and myocardial injury. So these are the effects on the cardiovascular system. On the other hand, in the kidney, they cause glomerulosclerosis. Again, the arteries or the capillaries, they again undergo the same changes. So there is glomerulosclerosis in the kidney, tubular inflammation is there, and finally there is kidney fibrosis, or the patient goes into end stage or CKD. And again, in development of many metabolic risk factors. So basically, this inflammatory mediators released by adipose tissue, they damage all the organs. And apart from this adipose tissue, ectopic fat, this can be a local source of mediator and can produce compressive organ damage also. Means the fat which is deposited anywhere in the body, it can compress the organs, especially when it is deposited in the epicardium, pericardium. So it can obviously have compressive effects on heart, and that can result in the development of arrhythmogenesis. There can be development of arrhythmias in the heart, myocardial dysfunction, coronary atherosclerosis, and within and around the kidney, it can lead to hypertension and abnormal blood pressure variability. So basically, These are the risk factors: abdominal obesity, dysglycemia, atherogenic dyslipidemia, hypertension. And these risk factors, what do they cause? They cause endothelial dysfunction, they cause atherogenesis, they cause thrombosis, myocardial injury, fibrosis, and cardiac remodeling. So basically, what the AHA has said is this fat or the excess adipose tissue, it can result in almost all types of cardiovascular diseases, not just atherosclerosis. It can result in any type of cardiac disease. Like it can even result in heart failure. It can even cause arrhythmogenesis that we have seen here. How does it cause? It can cause arrhythmias. In arrhythmias it can cause obviously atrial fibrillation. Even the sclerosis part, the degenerative part, it can result in aortic stenosis, and it can even cause pericarditis type of feature. So basically, it can cause any type of cardiovascular disease, this obesity. So basically, these are the main four mechanisms by which this adipose tissue or this metabolic risk factors, they cause organ damage. One is the hemodynamic mechanism, one is the metabolic mechanism, one is inflammatory mechanism, and one is fibrotic mechanism. So this is the in a nutshell the pathophysiology of the CKM syndrome. Again, it starts with adipose tissue dysfunction, leading to release of inflammatory mediators, which causes increase in the free fatty acids in the liver, which causes insulin resistance, vascular stiffening, development of plaque and atherosclerosis. Development of atherosclerosis on heart, then it can result in atherosclerosis, myocardial remodeling, fibrosis, cardiac dysfunction. Another thing, what this excessive adipose tissue can do is this activation of RAS and the sympathetic nervous system. This activation of RAS will obviously result in plasma volume expansion, and it will cause hypertension. So this is again how obesity leads to development of hypertension. One thing is obesity obviously also increases the peripheral vascular resistance, and because of this also there is cardiac dysfunction also, and there is development of hypertension also. It activates the RAS system as well as the sympathetic system. Again, that leads to hypertension. And in the kidney, it causes the tubular inflammation is there, gradually leading to tubular necrosis also. Then glomerulosclerosis is there, and gradually this leads to decrease in renal function. In earlier stages, again, there is a stage of hyperfiltration in the kidneys. That's why generally in diabetes, we get to see that in early stages, there is increased kidney size, or there is increase in the GFR in early stages. So that is because of hyperinfiltration, which is because of this activation of RAS system also, and because of this sympathetic system is activated. So finally, where does this CKM syndrome lead to? It can lead to complications in almost any system. Basically, I told in cardiovascular system, it can lead to almost any type of cardiovascular disease, either it be coronary heart disease because of atherosclerosis, atrial fibrillations because of arrhythmias, heart failure, which is an end result of almost any cardiac event, aortic stenosis. Apart from that, it can cause vascular complications because of this vascular remodeling or the endothelial damage. It can result in ischemic stroke and thromboembolic events. And the upregulation of this renin, angiotensin, aldosterone system and derangements to metabolic pathway, it can also promote pulmonary vascular disease, that is the pulmonary hypertension, right-sided heart failure. So only lungs was remaining, that is also now getting involved. So there can be development of pulmonary hypertension, right-sided heart failure also because of this obesity and all these metabolic things. And obviously, in kidney, it can lead to progressive loss of kidney function, gradually making the patient going towards end-stage renal disease. In pregnant females, there is an increased risk of recurrent preeclampsia. This is what the AHA has observed in its studies, that a female who is having preeclampsia in her first pregnancy or in any of the pregnancy, and in between this pregnancy and next pregnancy, if the female is suffering from metabolic syndrome, she is obese or she is having impaired glucose tolerance or impaired lipid profile, so she will be at more risk for preeclampsia in her next pregnancy also. So there is increased risk of recurrent preeclampsia. So that's why now the guidelines are suggesting that weight optimization for a female who has suffered from preeclampsia in her first pregnancy, her weight should be optimized before the next pregnancy. Otherwise, she will be at risk for developing preeclampsia in her next pregnancy also. And again, this is a newer study which has shown or documented that CKM syndrome or patients suffering from metabolic risk factors, they are having accelerated cognitive aging. So the degenerative diseases of mainly of the cognition like Alzheimer's. So these are more common in persons, in people who are having metabolic risk factors. And this is one important point which I thought that it should be mentioned, that how much is screening important to look for this risk factor. So AHA, it recommends screening for cardio-kidney metabolic syndrome should begin at 2 years of age if there is a family history of either early cardiovascular disease or significant hypercholesterolemia. So if a child is having family history for this metabolic diseases, the screening should begin as early as 2 years of his life. So these were some important points related to the basics of the cardiovascular kidney metabolic syndrome. So main thing is understanding the pathophysiology and how it progresses so that we can understand its complications better. Now we will have staging, and lastly the therapies. So this therapy are mainly directed at this pathophysiological roots of this CKM. And these were the references for my today's lecture. Thank you very much.
Thank you, sir. You can now stop sharing your screen. Thank you for in-depth as a very dedicated person for the field, and that can reflect from your talk. So thank you. And diabetes mellitus in sorry, I would like to mention that cardio-kidney metabolic syndrome. The speaker who was about to take it, Dr. Sachin Sumanges, due to some unavoidable reason, is not available. So, we will try to compensate the topic in time, but so that we have now diabetes mellitus and cardio-kidney metabolic syndrome, a very wide and most important aspect for the prognosis of the patient, and will be covered by one of the very dynamic person, Dr. Sohail, Dr. Ehsan Sheikh, sir, Director and Consultant Diabetologist at the Diabetes Care Center and Kushi Women's Hospital, and serving in Chhatrapati Sambhaji Nagar, Aurangabad. Last 15 years, more than 15 years. Sir was investigator in landmark trial and has delivered many talks in the webinars, national and international conferences. So I call upon Dr. Ehsan Sheikh, sir, to kindly share the screen and enlighten us.
Thank you. I am audible and visible? Yes, thank you. Thank you. Can you give me the sharing rights?
Yes, sir.
My slides are visible?
Yes, sir.
Visible? Okay, fine. Yes. So, good morning, all esteemed delegates. At the outset, I would like to thank the Elite Academy for arranging such a good academic platform for all the healthcare professional and improving their knowledge time by time. Actually, you are doing a great and noble job actually for accredited points for the consultants. The today's topic of selection is diabetes mellitus and CKM syndrome. So we know that we are in the Asian incontinent actually, right? And in the background of strong genetic predisposition, our faulty lifestyle habits are imposing a lot of metabolic diseases in India particularly, and we are the second largest capital of diabetic population. So basically the CKM syndrome is nothing but the combo of diabetes kidney problem, cardiovascular illnesses, and in the background of strong genetic predisposition. So basically, this syndrome is nothing but the combo of the sharing the common a common underlying pathophysiology for diabetes, hypertension, dyslipidemia, which leading to uh, cardiovascular illnesses in the future and would leading to the renal problems in the future. So this is the basically the common illness sharing the common pathology and having consequences in the future life. So this is going to be in the stage wise approach in the patient's life. Actually, one disease is coming, then after that disease is related with the common pathology of insulin resistance and deficiency, which leads to hypertension in future life. In the background of obesity, that leads to dyslipidemia. Both this combination of obesity, diabetes, hypertension, stress, lack of sleep, and other lifestyle modification leads to the increase the risk of cardiovascular illnesses and kidney problems as well. As previous speaker has mentioned about all the pathophysiological process of the CKM, cardiovascular kidney metabolic syndrome, in very detail. Unfortunately, the staging part has not been covered, and it will be covered in the subsequent talks. Actually, I will be restricting my talk in 15 to 20 minutes. I will be giving you highlight about the diabetes and the CKM syndrome, how to approach particularly diabetes in this metabolic syndrome problem. Actually, right? So the CKM syndrome is a health disorder. Why it is important? Because in as a Asian in continent, as a Indian patients, we are having a very strong genetic predisposition for metabolic illnesses, because we are having a different genetic constitution in the form of very high visceral fat percentage. Number one, high insulin resistance at lower BMI. Number two, number three, our conversion of pre-diabetes to diabetes is very high, and we develop diabetes, blood pressure, dyslipidemia a decade ahead as compared to Western population. So with this strong genetic background, if we have a defective lifestyle in the form of erratic food habits, lack of sleep, stress, and multiple addictions, then this will cumulatively accelerate the metabolic process, and that is the reason why our young population is getting affected more with the diabetes, blood pressure, heart diseases, and stroke, and all these metabolic diseases, particularly this cardiovascular kidney syndrome. Actually, so this is the reason why, if you see the numbers of the metabolic parameters or metabolic illnesses in our country, you can see here diabetes is common to the tune of, we are having population of 135 or 140 crore, and among that 10 crore patients are already been diagnosed with type 2 diabetes, right? The pre-diabetic stage, which is the previous stage of diabetes, it is there in our country to the tune of 13.6 crores of patients. So if you combine diabetes and pre-diabetes, that is contributing to 25 crores of patients actually. And the more worrisome and most worst part of that is already 50% patients are undiagnosed. Still 50% patients are undiagnosed. So we can see the potential, how much that diabetes and pre-diabetes is there in our country. So almost 1 out of 4 patients is already having either diabetes or pre-diabetes. So, and that too, that disease is affecting the younger, productive, and working class of population, in spite of the rural and the urban division actually. So this is very important, that working class is getting affected with this disease, and believe me, this disease is going to be lifelong, this disease is going to be chronic, this disease is going to be progressive, and this is going to affect the quality of life of the patients. It is going to affect the productivity of that family. It is going to affect the productivity of the nation as well. Now coming to see the numbers of the hypertension, they are still more. 31 crore patients are having hypertension. If you see the generalized obesity, it is to the tune of 25 crore patients. And if you see the abdominal obesity, particularly, which is a marker of insulin resistance and the pathology of this metabolic this CKM syndrome, that is there with the tune of 35 crores of the patients actually, and hypercholesterolemia 21 crore 20. So you can see this number, how rapidly these numbers are increasing. If we are having strong genetic predisposition, it is our duty to maintain that lifestyle, prevent the disease, this type of diseases to the tune of very less percentage, so that our younger population can get less affected with this type of metabolic illnesses. So this is the need of the arm. We need to upgrade ourselves as far as health care is concerned, because our health is our responsibility. As I already mentioned, these are the numbers. Still 50% patients are undiagnosed. Our rate of conversion of pre-diabetes to diabetes is very high. And that is the reason why we need to be very careful regarding the this type of metabolic illnesses in our setup. Okay. If you see whenever we are treating a type 2 diabetes, actually this is the disease of lifestyle actually, right? So we have to guide the patient according to the lifestyle changes, like proper diet, proper exercise, in implementation of program, proper weight loss management, and on the top of that, we need to give them the adequate doses of medicines with proper care. We need to give them the additional dose of the medicine actually, right? Now, so this approach has to be very clear and very stringent with all the healthcare professional, because many times patients are not coming to directly to the specialist. Right, our 50 to 60% population is being treated by the in the rural areas by the general practitioners, and if you upgrade their knowledge for the proper and stringent care of these metabolic illnesses in the light of guidelines, that is going to helpful in the future life. Because if you can see the recent data of ICMR in-depth study shows that only 69%, only 30% patients are under control of HbA1c less than 7%. So 69% patients are still uncontrolled. More than 8% HbA1c is seen in 54% of patients. More than 10 HbA1c is seen in 25% of the patient. So if you are having this type of care for our young patients, so we can imagine the risk of complications in the future life. Why we are discussing this CKM problem? Because we have to diagnose this combo of metabolic parameters very early in the stage of a patient's life, so that we can do the stage wise interventions, so that we can prevent this development of these metabolic illnesses like diabetes, hypertension, dyslipidemia, and we can further reduce the risk of developing the cardiovascular illnesses and CKD in the future life. That is the reason why we should know the potential of the illnesses. And can you imagine, this is the care what we are our patients are getting in our country. The aim of the WHO is to increase that 30 number of control patient to 50% of the patient should get HbA1c control by 2030. This was the objective of the WHO actually. So now coming to the risk factors, like in the background of strong genetic risk factor, the chronic conditions like psoriasis, RA, lupus, they have also got risk of potential developing this CKM syndrome. High risk demographic group like South Asian countries have ancestry has a strong genetic predisposition. High burden of the social determinants of the health. Mental health is increasing. Sleep problems are increasing due to increasing obesity. The risk of gestational diabetes, PCOS, premature menopause. All these are the risk factors for developing the CKM syndrome. Now, if you see, now I'm coming to the care of the CKM, particularly in respect of diabetes in the CKM syndrome. Actually, if you see the guidelines recently, the guidelines has entirely changed their paradigm from the glucocentric approach to the cardio-centric approach and the cardio-metabolic centric approach actually. So they have now the treatment of diabetes is not only about the glycemic control, it is about taking care of beta cells, it is going to be taking care of the reduction in the fat percentage of the body, weight reduction, and the further cardio and renal benefits in the future life. So we need to give the treatment in such a way that that patient should get the multiple benefits. Besides good glycemic control, we should use the molecules which give beta cell protection for longer duration of time, which will take care of the fat reduction, which will take care of weight reduction in the body, which will give a protection to the heart and give protection to the kidney in the future life. So we have to follow this regime of guidelines, particularly in the new onset patients or younger patients, to give the maximum benefit in the future life. So these are the rationales of the staging. Why this staging is important? Because each stage represents an opportunity for the prevention of for the preventive interventions actually, right? As you know, we are studying since morning, there is a substantial overlap of the cardio renal metabolic conditions. Like now we know that 35 to 40% patients of heart failure have the CKD. 30 to 40% patients of type 2 diabetes have a CKD. 76% patients of CVD and diabetes have CKD. 30% patients with the coronary artery disease have diabetes. So all the diseases are share the common pathophysiology. They share the common a mixing of the complication, and all are interrelated actually. So if we are controlling or if we are providing the benefits in one system, that benefit is going to get propagated in the the benefit in the other system as well, right? As I mentioned, the dysfunction in one of the system has a compounding effect on the other system. So improvement in the function of the system can have a multi-system of benefits, that is CV, renal and metabolic interdependency emphasize the urgency for integrated care. So we need to give an integrated care and not only restricting ourselves just to the glycemic control. Now, this is the holistic approach for cardio-renal metabolic care in early life. As I mentioned, as this is a lifestyle disease, we have to take a very good care of lifestyle in the form of good physical activity. I mean, this lifestyle is going to be covered very in depth by Dr. Balesar in the subsequent talks. So, the physical activity, dietary restrictions, reduction in the form of tobacco in any form, adequate sleep of 8 hours is very, very essential, and it is a part of lifestyle modification. Now, coming to the essential treatment for the risk factor control, we have to give a very good anti-diabetics to control the blood sugar levels, but the use of that anti-diabetic should be in the light of guidelines. Like we have to use them, and it depends upon the HbA1c of the patient, it depends upon the symptomatology of the patient, it depends upon the comorbidities of the patient, it depends upon the his risk appetite of managing weight gain or hypoglycemia, his economical status, everything we have to anticipate and consider, and we have to write the anti-diabetic, but strictly in the background of the guidelines actually, because we have to preserve beta cells, we have to use molecules which causes weight loss, we have to use molecules which gives cardio renal protection in the long run. So this is the very important insight we need to understand, and definitely we should not hatch to use the very good molecules, and we have to overcome with this inertia of using a good molecules in right patient at right time, so that we can pass on the benefits of such a good molecules, which I'm going to discuss in the further talk. Simultaneously, we have to control blood pressure, we have to control the weight of the patient, and the essential treatment, organ protection, everything is combined to give the combined benefits in the future life. So these are the recent ADA 2026 guidelines. If you see these guidelines carefully, healthy lifestyle behavior and diabetes self management education is very important. Diabetic education is the key and cornerstone of the management of diabetes. Patient should know what approach I need to follow in my life to control my diabetes actually. And my diabetes is a lifestyle disease. What exact diet I need to follow, what exercise I need to follow, and what is the strength of exercise I need to implement in the life to get the metabolic benefits. Then what is the importance of taking adequate medications, and how to I need to screen the I need to screen my parameters like fasting, post meal, HbA1c, the ambulatory glucose monitoring profile, then lipid profile. Every yearly I need to supposed to check my risk of complications. I need to take care of food. I need to take care of hypoglycemia if at all I'm having. So this is all part of diabetic education, and it is a cornerstone. Patient should be aware that this diabetes is going to be a progressive disease over a period of time. The severity of illness increases, the dose of oral hypoglycemic agent increases over a period of time, and somewhere down the line, 10 years, 12 years, or 15 years down the line, patient require insulin in the management of type 2 diabetes to control HbA1c, to control the glycemic excursion, to prevent the complications. So if patients are aware, then they will focus more on diet and weight loss management and proper exercise implementation program, so as to reverse, or so as to reduce the progression of the illnesses actually. So diabetic education is very cornerstone. And what is the role of the healthcare professional? Role of healthcare professional is to upgrade, to reinforce, to all the approaches onto the patient, and use the molecules which are the organ friendly, which are beta cell friendly, which are the weight friendly, and gives rise to pleiotropic benefits. So there are two parameters, like one is the cardiovascular and kidney risk reduction, and here is the achievement and maintenance of the weight and the glycemic goal. So they have given the stress on the glycemic goals, they have again stress on the weight management. Now here you can how much weight loss that metabolic benefit starts actually. So it is the 5% weight loss which is mandatory. Give small targets to the patients. 5% weight loss in 6 months, next 5% weight loss in next 6 months. These are the small targets and achievable and encouraging targets for the patient, for the proper, with the proper exercise and proper diet. Along with that, if you want to accelerate the weight loss, see, this much 5% weight loss is very well acceptable and possible with proper lifestyle modification, and the diet and exercise actually, but and the proper counseling. But more than that, weight loss needs actually pharmacological therapy. So there is a gap in between the 5 to 10% or 15% weight management, and we are now having a very good molecules for the weight loss. These are not, but these are nothing but the GLP-1 receptor in the form of agonist in the form of tirzepatide, that is Mojaro. And these weight loss drugs are very effective, and that has to be introduced early in the management of a patient, so that they gives rise to a very good fat loss, particularly visceral fat loss. They manages. I'm going to talk in detail about these molecules in the talk. They gives rise to, they are hitting at the pathology of the development of type 2 diabetes. Particularly, they are extracting visceral fat loss and reducing the appetite, reducing the diet of the patient, and giving rise to gradual weight loss to the tune of 15 to 20%, 15 to 20%, and that is helping the patient to stop the pathogenesis process of type 2 diabetes, and that is gives rise to tremendous metabolic benefits in the patients actually. So, and the very high effective molecules like semaglutide, trizapeptides are available. The other intermediately acting molecules are like dulaglutide and liraglutide are also available, and some neutral molecules like metformin and DP4 inhibitors are available. So I'm talking about weight loss management. Now coming to the diabetic management, we have to use the molecules next to metformin. we have to use the molecules like SGLT2 inhibitors or DP4 inhibitors if patients are according GLP-1 RA. So these are the priority of sequence of using molecules to control the diabetes actually. And if you are using this GLP-1 RA or SGLT2 inhibitors in our patient, as the guidelines mentions, the patients with established ASCVD, the patients with high risk CVD and heart failure and CKD, all these molecules are going to be beneficial. So the class 1 recommendation by the guidelines is GLP-1 RA, SGLT2 inhibitors if patients are having a heart failure, and if SGLT2 inhibitor if patients is having CKD or GFR more than 20, we can definitely use SGLT2 inhibitor till the patients reach up to the end stage renal disease. And to some extent if so this is how we have to develop an insight to treat the patients, not only focusing on the glycemic control. We have to equally focus on the weight loss, we have to equally focus on the cardiac and renal health of the patient actually. So this approach has to be adopted as early as possible to give rise to the benefit to our patients. So as I was talking regarding the weight loss benefits, give small target of 5% weight loss, which is going to give a good HbA1c reduction. But if you really want to reverse the disease or stop the disease process, we need the weight loss to the tune of 10 to 15%. So what are the benefits at weight loss stages? I'm going to talk. In type 2 diabetes, 5 to 15% weight loss gives rise to good reduction in HbA1c. It will reduce the dose of the oral hypoglycemic agent. There will be upregulation of GLUT4 receptors. Whatever medicines we are using, they act in a better way. And I have seen that if patients are having weight loss up to the tune of 15 to 20%, patient need to stop their insulin as well. The dose of oral hypoglycemic agent comes drastically down, and many patients with long-standing diabetes with this type of weight loss of 15 to 20% can go into the temporary remission as well. Metabolic syndrome, as we are discussing since morning, the 7 to 10% weight loss gives rise to prevention of diabetes. NFLD, as our previous speaker has mentioned, the non-alcoholic fatty liver disease, now it is the term changed to MSALD, metabolic associated non-steatofatty fatty liver disease. This is the very hot topic nowadays. Many patients with normal weight also are having fatty liver, and we need to assess the degree of fatty liver, and it is the time to treat because it is a marker of insulin resistance, it is a marker of cirrhosis. And these metabolic illnesses, though patients are not having any background pathology like alcohol and all, these patients are, I'm seeing younger patients are getting progressing toward the cirrhosis due to this fatty infiltration of the in the hepatocyte. So this is the time to reverse the fatty liver, this is the time to reverse the diabetes with proper knowledge and proper care actually. PCOS can get benefits if 5 to 15% weight loss will, there will be normal ovulation, there will be reduction in the insulin resistance and hirsutism. Dyslipidemia get benefited with the 5 to 15% reduction in the triglyceride, LDL and HDL. Blood pressure also get benefits with the 5 to 15% weight. Sleep apnea is very common problem in younger population with the strong obesity, and we know that there is no drug for the sleep apnea. There is no drug for NFLD approved right now, except some GLP-1 RA and some other medications like saraglitazone. The all these parameters can get improved with the weight loss actually. So targeting primary pathology, though it is multifactorial, targeting primary pathology without medications, with proper lifestyle modification, with proper knowledge is very essential. So give the target of 5% weight loss for 6 months, work on that. Try to encourage our patients, give them reinforcement of importance of diet and exercise, which is contributing to near about 60% patients, 60% treatment of type 2 diabetes, very essential. All these guidelines like ESC recommendation class 1 therapy for CKM syndrome management, these the same guidelines here you can see. we have to first evaluate the patient. If we confirm that the diagnosis is type 2 diabetes and ASCVD, GLP-1R is the first choice, SGLT2 is the second, again first choice in the heart failure patient. SGLT2 inhibitor is first choice in the heart failure patient. And here you can see in the kidney diseases, SGLT2 inhibitors like renoproven SGLT2 inhibitor like dapagliflozin and empagliflozin, they help to prevent the proteinuria. They help to prevent the further progression of that stage of CKD to the end stage renal disease. And the final one is nothing but the MRA, the agonist, which helps to prevent the proteinuria, reduce the proteinuria, and prevent the further progression. This is nothing but the non-steroidal mineralocorticoid agonist. These are helpful for the progression to maintain the normal function of the kidney to a maximum strength. So all guidelines are mentioning. So these are nothing. These are the KDIGO guidelines. Again, same. Next to metformin, we have to use the molecules which helps to reduce weight, like SGLT2 inhibitors, which will give rise to benefits in the HbA1c, which helps to give benefit in the CGM as well. RAS inhibitors are important, as our previous speaker was mentioning, to control the urinary albumin creatinine ratio to reduce the blood pressure, and moderate intensity statins are also important. ADA guidelines mention type 2 diabetes with one comorbidity, age more than 40, patient has to be on statins for the lifetime, because in spite of the LDL levels, the quality of lipids in the diabetic patient is very heterogenetic. These are the high and dense LDL, which gives rise to high heterogeneity, and we to reduce the quality of that lipids, we have patient has to be on high intensity statins and maintain the targets of LDL, triglyceride, and total cholesterol, non-HDL cholesterol as that of guidelines. The additional risk beneficial therapies like GLP-1 RA, I'm going to talk, the non-steroidal MRA. The second choice for blood pressure is the calcium channel blockers and antiplatelet, according to the need of the patient actually. So this is the approach we need to follow. The ESC 2024 also guidelines also mentions that in spite of glycemic control, independent of glycemic control, GLP-1 RA, that is semaglutide, is recommended as the class 1 and level A indication for the chronic coronary syndrome. Chronic coronary syndrome. This is very important. These are the European Society of Cardiology guidelines. So these are now the drugs are becoming like the universal drug for the management of the weight loss and give the cardiac benefits. These are the further future new compounds. Like I'm going to talk a few things regarding the semaglutide. The semaglutide is the once weekly or OD. It is available in two forms, like injectable form and oral form. Semaglutide is GLP-1 receptor agonist actually, and it has got tremendous weight loss benefit. It has got the benefit in terms of glycemic control, tremendous weight loss benefits, cardiac benefits, renal benefits. There are benefits in the sleep apnea, benefits in the PCOS. Now the ongoing trials in the asthma are also going on. So this semaglutide is available. You know that all the molecules like the Wegovy or Zempic are available, as we need to give them injection once in a weekly, in the upgrade or increasing the doses over a period of the treatment has to be targeted for the initially 15 to 20% weight loss up to 1 to 1.5 year. If patient achieves that, try to reduce the dose and maintain that weight loss to get the maximum benefit. So Wegovy and this Ozempic are available as an injectable GLP-1 agonist for the treatment of weight, for the treatment of glycemic control in our patient. These are the ideal for the patients like CKM syndrome. New molecules like newer molecules like GLP-1 and GIP is nothing but the Monjaro, which is or Urpic, which is the trizapeptide. This molecule is also has to be used in the injectable form. It is available in the form of 2.5, 5 milligrams, 7.5, 1 and 1, 2.4 milligram. The dose has to be incremented every monthly. This will act on the satiety. It will reduces the appetite of the patient, and it will gives rise to visceral fat loss. Particularly, to some extent, patient may have the muscle mass in the long run, but in that situation, to prevent that sarcopenia, we need to give them a proper high protein diet and multiple this muscle building exercise as well in the future life. So if patients are achieving 15 to 20% weight loss with this type of molecules, there are some side effects, like because these molecules are acting on the gastrointestinal tract, the patient may have nausea, vomiting, or loose motion sort of thing. There are some restriction to use these molecules, like we need to screen the patient for retinopathy, we need to screen the patient for medullary carcinoma, we need to see these his sensitivity and risk of pancreatitis. All these parameters we need to assess, and we can use this molecule. Believe me, 5% weight loss can seen in 9 out of 10 patients. 15%, 10% weight loss seen in near about 75% of patients, and 20% weight loss is seen in near about 30% of the patient with the use of these molecules actually. So the future is going to be the use of the weight loss management therapy to prevent the development of diabetes, to pass on the benefits in terms of cardiac and renal parameters, because all these molecules are going to be helpful. Now this is the GLP-1 and GIP RA, that is the trizapeptide what I was talking about. Another molecule which is in pipeline is the Cargi SEMA. Cagri SEMA is nothing but the carilinetide and semaglutide combination, and it is nothing but the medicine for the weight loss. Both are available in the combo as a once a week injection. What is this cagrilinetide? So it is nothing but the amylin analog. Now, what is amylin? Amylin is the polypeptide hormone which is secreted with the insulin in the ratio of insulin to amylin ratio, which is normally seen is 100 to 1. It is secreted by the beta cells. So, what is the role of amylin? Amylin secretion is also reduced in type 2 diabetes. What is the role of this amylin? This amylin reduces the, here you can see here, this amylin can reduces the appetite, it reduces the energy intake, improve the satiety, it reduces the gastric emptying, it reduces the glucagon secretion, it regulates the responsiveness to leptin actually, and it increases the renin and aldosterone secretion. So amylin is deficient and not there or less produced in type 2 diabetes. Amylin analog, which is a primylinityde, it is a synthetic amylin. It is not available in India, but very soon we are going to get this combination of the amylin and the incretin actually. All right, so this is called as the amycretin. Amycretin is GLP-1 and amylin co agonist. So very soon we are going to get these molecules. These molecules are helpful to control blood sugar level, to reduce the glucagon, they improve the weight loss, and we may see the weight loss of to the tune of 20 to 25% with the use of this injectable therapy. And the half-life of this molecule is going to be 180 hours, so 1 week. So it has to be very patient compliant, and this will give rise to a very promising results in the future, because we can use these molecules in very early stage of management of type 2 diabetes or in pre-diabetes. If we are identifying, see, our aim is to identify this type of CKM patients. We find out the the affecting risk population with the CKM patients, try to assess their metabolic parameters, and try to implement the good lifestyle changes in them so that we can prevent the development of this disease. And with the help of these type of molecules, if we are achieving the good weight loss of 10 to 15% or 20%, then we can definitely stop the pathogenesis of developing CKM syndrome. We can reverse or we can stop, get temporary remission of development of this CKM syndrome. One more molecule, which is the triple agonist, that is GLP-1, GIP, and glucagon receptor agonist, that is the retatrutide. And this is also very promising as far as the glycemic control, cardio-renal benefits are concerned, and weight loss is there. So the take-home message from my today's talk, as I was focusing on the diabetes in the CKD, our population is highly potential of developing diabetes and CKM syndrome. Our still 50% patients are undiagnosed. We are already having very high fat percentage, high insulin resistance as lower BMI. We develop diabetes 10 years ahead as compared to Western population. So our responsibility as a healthcare professional increases. We have to diagnose early, good give a good and maintain the high standards of care in terms of healthcare professional, upgrade their knowledge, upgrade their guidelines so that they can have clear and good approach towards our young patient. Education, educating patients is the key, and we have to give a cumulative and combined care as far as glycemic care, cardiac care, and kidney care is concerned, and weight loss care is concerned, to prevent the deadly complications like end stage renal disease or the heart failure or the end organ damages particularly. So our aim is to early diagnose the patient, do strong early interventions, and give a very good combo care now in terms of in the light of guidelines for our patients, because we are very soon going to become the capital of the CKM syndrome in the world. So this is all about the diabetes and CKM syndrome. Thank you. Thank you very much for the patient hearing. If there are any questions, I will be happy to answer them.
Thank you, sir. You can stop sharing your screen.
Yes, thank you. Thank you for the opportunity. Thank you, all esteemed delegates.
Thank you, sir. Actually, the pleasure is all ours to hearing you everything, the guidelines that you have mentioned. So, thank you very much, sir. Uh, for our next talk, I now call upon for a lifestyle modification in cardio kidney metabolic syndrome. It will be discussed by none other than one of the most fit HOD that I have seen, Dr. Ajit Bhale, sir, Professor and Head of Biochemistry Department at Indian Institute of Medical Science and Research. Sir is scope certified obesity expert consultant, diabetes at consultant diabetologist at First Diabetes and Obesity Clinic in Chhatrapati Sambhajinagar, with a clinical experience of more than 10 years and teaching experience of more than 25 years. I request to kindly unmute him and share the screen. Dr. Bale, sir.
Yes, sir. Just 1 minute. I'm trying to share my screen.
Yes.
Uh, can you tell me whether it is shared?
No, sir, it is not shared. Now we can see your screen.
Yes, yes. Thank you very much. Good morning, everyone.
Fine, sir. Sir, you can go to the slide sharing view so that full screen will be visible.
Mm, okay, well. Can everyone see the slides?
Yes, sir, we can see your slides.
Okay, shall I start?
Sir, slide show view if you can. It is there in lower corner. Yes, sir.
Okay.
Yes, sir. You can start if you are comfortable.
My slide sharing view is disabled, I think.
Okay, okay, sir. You can start. We can see your slides. Your slides are visible.
Okay. So today we'll continue our discussion with cardiovascular, kidney and metabolic syndrome. It is a newly named syndrome. It is a syndrome that is recently named and the name is cardiovascular, kidney and metabolic syndrome, also called as CKM syndrome. So let us revise our knowledge with CKM syndrome. What is the CKM syndrome? It includes number one, cardiovascular disease, number two, kidney disease, and number three, metabolic dysfunction. So cardiovascular disease, it includes, now many doctors have seen regarding cardiovascular disease. Many people they think that it is only about heart, but no. Cardiovascular disease, it is all about number one, CAD, that is coronary artery disease. Number two, cerebrovascular disease that may lead to stroke. Number three, peripheral artery disease that is PAD. Number four, rheumatic heart disease. And number five, congenital heart disease. So CVD is all about CAD, stroke, peripheral artery disease, rheumatic artery disease, and congenital heart disease. Now CKD we know if eGFR, estimated GFR calculated by Cockcroft and Graf formula, is less than 60 ml per minute for more than 3 months, then we diagnose the patient to have CKD, that is chronic kidney disease. What comes under metabolic dysfunction in CKM syndrome? Under metabolic dysfunction come number one, obesity, number two, IR, that is insulin resistance or diabetes mellitus. Number three, hypertension. Number four, dyslipidemia. And strictly speaking, MASLD, that is metabolic dysfunction associated with liver disease, steatotic liver disease, it also comes under metabolic dysfunction. But I have not mentioned MASLD here because most of the times obesity is the main cause of MASLD. And there is MASLD associated with non-obese also, non-diabetic may also may have fatty liver or MASLD, but most of the cases of MASLD they are associated with obesity. And since we are going to discuss obesity in detail, best treatment for MASLD is obesity. No doubt various drugs are there for treatment of MASLD, fatty liver, steatosis, NASH, MASH, but the best treatment for MASLD is weight loss, and with weight loss in most of the cases fatty liver literally goes off. So I have not discussed this entity separately as we are going to discuss obesity and weight loss in detail here. So metabolic dysfunction, primarily it is the metabolic dysfunction that leads to cardiovascular disease and chronic kidney disease. So we are going to focus on metabolic dysfunction. Is anything there that can use to address this particular thing, metabolic dysfunction, that we are going to discuss? Can anything be done to address this metabolic dysfunction so as to number one, prevent CKM syndrome or revert this CKM syndrome or slow down the progression of CKM syndrome? Let us see. Yes, number one, obesity. Now there are a lot of myths related to obesity, but strictly speaking, what is the International Obesity Federation definition of obesity? Obesity is a chronic disease. It is a complex disease. It is a heterogeneous metabolic disease that needs lifelong intervention. So what does this heterogeneity means? Heterogeneous is the most important word here in obesity definition. Heterogeneity means that response of obesity to various types of treatments is different. A particular anti-obesity drug acts very well in a particular patient, but the same drug fails in a different patient. Vice versa may be the case in another patient. So this is called heterogeneity. And the most important feature of obesity is heterogeneity. And because of this heterogeneity, obesity has become a very chronic disease, very complex disease that needs lifelong intervention. And what are the causes of this heterogeneity? The main cause is that there are more than 13 hormones related to your feeding behavior and appetite regulation. So these 13 hormones, their receptor for these 13 hormones, genes for these 13 hormones. That is why obesity is a very, very complex disease to treat. And in most of the patients, once you stop the intervention, weight regain is there in almost 100% of patients. These things we have to understand while treating obesity first. So there are basically two types of obesity. Number one is generalized obesity, and number two is visceral obesity. Nowadays we call it metabolic obesity. Visceral obesity, we call it as nowadays metabolic obesity. So what is this metabolic obesity? In many patients we get to see that BMI is normal, the body mass index is normal. But when you do DEXA scan or simply body scan, body fat scan by measures like techniques based on bioelectric impedance, nowadays these instruments based on bioelectric impedance you will get to see in various gyms also, various obesity clinic also, they are cheap, but they are not very accurate. Bioelectric impedance based instruments, they are not very accurate. The gold standard for measurement of visceral fat is DEXA scan. And if you do DEXA scan, you will get to see that many people, they have normal BMI, but their visceral fat is more. It is above the normal range. This is called metabolic obesity. Now, BMI may be normal, but visceral fat is above normal range. This is metabolic obesity we have discussed. Now, I will give one classical example. See, the right person in this particular slide is Dr. Chittaranjan Yadnik, a renowned diabetologist in Pune. While on the left side, you can see Dr. John Yudkin. In one conference, they met around 25 years back. There, the device was available for measurement of body fat, visceral fat, subcutaneous fat, total muscle mass. So, they both did their body scanning, and it was revealed that Dr. John Yudkin, apparently looking overweight, and Dr. Chittaranjan Yadnik, apparently looking normal weight, both of them had BMI of accurately 22.3. But when body mass scanning was done, it was revealed that visceral fat in Dr. John Yudkin was 9.1%, much less than 12%. And regarding Dr. Yadnik, the visceral fat, it came to be 21.2%, much above the normal range. So BMI is normal, but visceral fat is more in case of Dr. Chittaranjan Yadnik. So this is called as metabolic obesity. The thin fat Indian concept, it came from this metabolic obesity concept only. Thin fat Indian. In fact, this particular term thin fat Indian has been coined by Dr. Yadnik sir only. And this phenomenon, which phenomenon? Normal BMI but more visceral fat, metabolically obese, thin fat Indian. This phenomenon is called as YY paradox. Why YY paradox? Y for Dr. John Yudkin and Y for Dr. Yadnik. So this is called as Y paradox. And this particular term, that is thin fat Indian, has been coined by Dr. Chittaranjan Yadnik only, and it has become now very popular term used everywhere. And this is a very popular site shown in many conferences related to obesity or metabolism or diabetes. Y paradox. So why this visceral fat is dangerous? Because these visceral adipocytes, they secrete some chemicals, chemicals like TNF alpha, chemicals like interleukin 6 and resistin. TNF alpha, IL-6, they result in inflammation, while resistin is responsible for increased insulin resistance that may lead to prediabetes or diabetes. While these visceral adipocytes, they secrete less amount of adiponectin. Adiponectin is a good chemical. It is called a good nectar. Though a nectar, it is a good. So adiponectin, it's called as a good nectar. So less adiponectin, so more insulin resistance will be there. Visceral adipocytes also secrete less endothelin. Less endothelin, more endothelial dysfunction. So why this visceral fat is dangerous? Less adiponectin is secreted, leading to insulin resistance. Less endothelin is secreted, leading to endothelial dysfunction. Then it secretes more of resistin, leading again to insulin resistance, more TNF alpha, and more IL-6, resulting in inflammation. That is why this visceral fat, visceral adipocytes are not healthy. No doubt, CKM syndrome is one of the complications of obesity, but other complications with obesity are insulin resistance and diabetes mellitus, hypertension, cardiovascular disease, OSA, that is obstructive sleep apnea, and you will get to see that many obese patients they complain of knee pain or hip pain because of osteoarthritis. So, if you can treat properly these metabolic derangements in CKM syndrome, you can effectively slow down the progression of CKM syndrome, or you can even revert the CKM syndrome. So, what are the components of this CKM syndrome? Metabolic derangement components. Number one, obesity. So, to obesity, we have nowadays three approaches mainly. Number one, diet. That includes number one, low carb diet or low energy diet. In diet intervention, there are two types. Number one, low carb diet, or number two, low energy diet. Then nowadays we have got various anti-obesity drugs to treat obesity. Previously, 2 years back or even 1 year back, only drug that was approved for treatment of obesity in India was Orlistat. It was the only drug available approved by DCGI for treatment of obesity, prandial lipase inhibitor Orlistat. It used to give weight loss at a tune of 3 to 4 kg in 3 to 4 months. Not very good weight loss, but better than nothing. Then nowadays we have various drugs. They are number one, most important, tirzepatide, GLP-1 receptor agonist, and number two, injectable semaglutide, that is GLP-1 receptor agonist. So tirzepatide is GLP-1 plus GIPI, GIP receptor agonist, dual agonist, while injection semaglutide, it is just GLP-1 receptor agonist that we have there in our armamentarium now for treatment of obesity. The problem with this drug is the cost. They are very costly. Injectable semaglutide, injectable tirzepatide, the cost of both drugs go around 15 to 80,000 per month. So there are certain restrictions while using these drugs. Otherwise, these drugs are very good. GLP-1 receptor agonist, as Sanshek sir discussed, these are wonder drugs. These are magical drugs. They give very good weight loss along with very, very good blood sugar control. And then for those having BMI more than 35 or BMI more than 35 with comorbid conditions, or BMI more than 40 without comorbid conditions, the best option, if no contraindication is there, is bariatric surgery. So anti-obesity drugs, as Sanshek had discussed, like GLP-1 receptor agonist, GIP, Bariatric surgery is a different domain. Today we will focus on dietary management of obesity for addressing metabolic derangements in Sikkim syndrome. So there are two types of diet basically for treatment of obesity. Number one is carbohydrate restriction, carb restricted diet. Carb restricted diet, again, it is of three types. Number one, low carb diet, where carb restriction is done at the tune of 25 to 30%. Number two, very low carb diet, carb restriction is done at the tune of 50 to 60%. And there is something like keto diet. In keto diet, carb restriction is done at the tune of 4%. Only 4% carb intake is allowed. But strictly speaking, keto diet should be performed in special cases under strict medical supervision. Yet, low carb diet, very low carb diet, they give very good weight loss. Now, the second dietary approach for management of obesity is low energy diet. So to use this particular low energy diet, you have to calculate something like TDEE, that is total daily energy expenditure of that particular person, by using one equation called as Harris and Benedict equation. By using this particular Harris and Benedict equation, it will take into account your age, your weight, etc. and it will give TDEE for that particular person. This is called as total daily energy expenditure. Once TDE is calculated, then restrict the calorie intake to one third of TDEE. Say, for example, a person's total daily energy expenditure comes to be 3000 calories per day. Then you have to restrict calorie intake up to 1000 calorie per day by using what is called as diet formulae. Nowadays in market, ready-made diet formulae, they are available. So why this diet formulae? Because what happens if you restrict calorie intake of person who consumes 3000 calories per day to directly 1000 calories per day, there is always a risk of deficiency of various micronutrients and macronutrients. This is the problem. When you restrict calorie intake directly from 3000 calories per day to 1000 calories per day, there is always a risk of deficiency of certain micronutrients and macronutrients. That this is why these diet formulae they are used. They are designed in such a way that around 1000 calorie per day will contain all the micronutrients and macronutrients according to the RDA, recommended daily allowance for them. So this is the importance of using this particular ready-made diet formulae. They are loaded with micronutrients, macronutrients, and at the same time they give calorie restriction benefits as well. And with this particular diet formulae, we can do up to 12 to 15% of weight loss in 3 to 4 months without any major side effects. So this thing we have discussed, anti-obesity drugs. Orlistat is there, prandial lipase inhibitor, and nowadays GLP-1 receptor agonists are there like tirzepatide or injectable semaglutide. Previously, dulaglutide was there, oral semaglutide was there, but they were not approved for use in non-diabetic patients. So what is the importance of injectable semaglutide and tirzepatide? They are approved for use in non-diabetics as well. This anti-obesity drugs, tirzepatide, injectable semaglutide, can be used in non-diabetic patients as well. Now let us discuss the next component of metabolic dysfunction in CKM, diabetes mellitus. So what is the dietary management for diabetes mellitus? Of course, you know well, choose food having low glycemic index, avoid food having high glycemic index, and ask the person to consume food with medium glycemic index in moderation. So you can see here high glycemic index. So most of things like bakery products, bread, pav, khari cake, toast, biscuit, sugary things, things containing good. People in India think that good is good and sugar is not good. No, it is not like this. Good and sugar both are having similar glycemic index. So ask the patients to avoid sugary things. Ask the patients to avoid bakery products, bread, pav, khari cake, toast, biscuit, uh, food prepared from rice like poha, dosa, idli, uttappa. These are all almost very high or high glycemic index foods. So medium glycemic index food, under medium glycemic index comes rice, chapati, and bajri along with jowari. So grains they come under medium glycemic index. If you want very good benefits in diabetes, ask the patient to curb food with medium glycemic index like chapati, bhakri or rice at the tune of 20 to 25%. The patient will get very good benefits, and ask the patient to have low glycemic index food in not in moderation, but they can have low glycemic index food like salad, vegetables, sprouts, chauli, matki, moong, rajma. Ask them to have in plenty. So stress-free lifestyle also gives very good results in diabetes management. Things like yoga or meditation can be tried for this. Then regarding exercise, yes, exercise gives tremendous terrific results in treatment of management of diabetes mellitus. There are two types of exercise we know. Number is cardio, number two is weight training. Cardio exercise give you numerous benefits, no doubt. Your cardiorespiratory performance increase, your VO2 max increase, your oxygen consumption increases, your resting heart rate drops down. So all these benefits are there with cardio, no doubt. But when it comes regarding blood sugar management, no doubt, weight training is far better than cardio. If you maintain your muscle mass, automatically you maintain your metabolic health. How we can see? Yes, you can share the slide. With weight training, what happens? The glucose transporters they are translocated from the cytoplasm to the cell membrane, and the function of insulin is same. Translocation of glucose transporters, same thing weight training is doing. Because of weight training, there is translocation of glucose transporters to the cell membrane, and glucose comes in. These glucose transporters they will transfer glucose from outside to inside of the cells. So translocation of glucose transporters is the major benefit with weight training that give you very good results in management of type 2 diabetes mellitus. Now let us discuss dietary management of hypertension. Now various types of diets they have been studied, extensive trials have been done regarding hypertension, but the best results regarding dietary intervention for hypertension have been seen under one trial, and this trial is called as DASH diet. What is this DASH? DASH stands for Dietary Approach to Stop Hypertension. So DASH diet is dietary approach to stop hypertension. It was an extensive trial, multicentric trials, and the results of DASH trials are considered very good regarding management of hypertension. So what is this DASH diet? See, various components are there in this DASH diet like consumption of grain, consumption of low fat dairy products, consumption of seafood, consumption of lean meat instead of red meat. Various things are there. But strictly speaking, when it comes to hypertension, DASH diet is all about number one, low sodium, number two, high potassium, and number three, high fibers. So total daily intake of sodium should be less than 6 gram per day. For those who are having hypertension, known cases of hypertension, total intake of salt, sodium chloride should be less than 5 gram per day. You can see a spoon. This spoon is 5 gram. So total intake of sodium chloride per day should not be more than 5 gram of this particular TSF, 5 gram TSF. If 4 members are there in family, you can use salt, sodium chloride at the extent of 4 teaspoons, such teaspoons per day. But the fact is that we Indians, we consume around 12 to 15 gram of sodium per day. I think maximum consumption of sodium is there in India only. So per day, we Indians consume 12 to 15 gram of sodium per day instead of 5 to 6 gram per day. Why? Because many people they have a habit to add additional namak in the diet, additional salt in the diet. We Indian people, we do snacking all the time, and most of our snacks are salty, like chips or shev or farsan like this. And these things, salty things like papad, lonche, kurdai, shev, farsan, these things, they contain a lot of sodium. Even bakery products like bread, people don't know that bakery products like bread, khari, they also contain lot of sodium. This is why, this is how we consume sodium at a tune of 12 to 15 gram per day. Maximum intake of sodium is there in Indians. So we have to restrict this intake up to only 5 gram per day to get benefit in hypertension. Let it be management of hypertension or let it be prevention of hypertension. Now, the second component in this particular DASH diet is high potassium intake, and we all know that potassium decreases blood pressure. All the fruits, all the vegetables, fruit like banana especially, coconut water, they are very good sources of potassium. So low sodium diet, high potassium diet and high fiber diet, they give very good results in management of hypertension. Now, what about the next component of metabolic derangement in Sikkim syndrome? Lipids. Yes. For management of cholesterol, number one, avoid saturated fat, including milk and milk products. Number two, red meat. Number three, egg yolk. Egg yolk is the richest source of cholesterol, followed by liver, followed by red meat, followed by milk and milk products. So you have to cover all these things to bring down serum cholesterol and LDL cholesterol levels. Nowadays, various messages they come there on WhatsApp University. They say that no dietary restriction of cholesterol is not needed. American Nutrition Association has given guidelines like this. No, fact is that no doubt there is something like feedback regulation regarding cholesterol synthesis in our body, in our liver cells. There is something like feedback regulation, but the fact is that this feedback regulation is not absolute. Evidence says, research trial outcome says that when you consume more cholesterol, when your diet contains more cholesterol, your serum cholesterol levels they rise. Because the reason is that this particular feedback regulation of cholesterol synthesis in hepatocytes liver cell, this feedback regulation is not absolute. So dietary cholesterol does affect your serum cholesterol levels, always remember. Then to bring down your serum triglyceride levels, restrict oil consumption and so as to get maximum benefit in weight loss as well. By restricting oil consumption, oil intake, you can get benefits of weight loss as well, and you can bring down your serum triglyceride levels as well. Increase intake of omega-3 fatty acids. These omega-3 fatty acid sources, they are limited. Regarding veg diet, they are present in flaxseed oil, walnut oil. But how many of us consume this flaxseed oil, walnut oil? Whatever omega-3 we are getting mainly from green leafy vegetables only. So we Indians, we consume very less omega-3. That is why we are capital of everything, capital of heart disease, capital of kidney disease, diabetes capital of the world, etc. Because we consume very less proteins, we consume very high carbs, we consume very high salt, and we consume very less omega-3 fatty acids. So intake of omega-3 fat should be increased in our diet. This omega-3 fats, best sources of flaxseed oil, walnut oil, and seafood. Yes, regarding HDL, statins they help increase your HDL level at a tune of 5 to 10%, not more than 5 to 10%. But exercise really helps increase your serum HDL levels. The best thing to increase your serum HDL levels, it is the exercise. So this was regarding lifestyle management, dietary management regarding CKM syndrome. Thank you very much for patient listening. Yes, I hope you can hear me.
Yes, 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 sir. Thank you very much, sir.
Yeah,
You
thank
can
you, sir.
stop sharing your screen. You can stop sharing your screen.
Okay, okay.
Thank you, sir, for all the minute details regarding the lifestyle modifications that you have covered in your talk. Before going to our next session, I would like to take attendance for all the delegates. So I request everyone to kindly keep their cameras on uh, for screenshots that we need to submit to the MMC. It will be very kind if everyone will smile. The madam is ready for the next lecture. I can see her.
Good morning, Dr. Zubair.
Morning, ma'am. I also
My
see.
voice is clear now. You are listening me
Yes,
clearly.
yes. I also
Okay, so
see.
you are, if you are done with the screenshot, should I share my screen with you?
Ma'am, I'll let you know just 2 minutes. Okay, so our next speaker is a dynamic associate professor from pharmacology department of MGM Medical College with list of achievements in her career. Few that could be mentioned at this point is she's gold. She has got two gold medal, a silver medal, and 14 honorary certificate UG career. With 15 years of experience in academics, she has more than 20 publications in index journal. Also, she has received the Young Researcher Award in 2023 and Adarsh Shikshak Award in 2012. So I call upon Dr. Shruti Chandra ma'am to continue her talk on pharmacology of CTM. And you can share your screen.
Okay, I'll share.
Yes, it is visible.
Okay. So, good morning, all. I would like to thank organizers for giving me this opportunity to share my views on pharmacological management of CKM syndrome. So, should I start, Dr. Zubair? Okay. So since morning, we have listened excellent talks about all these speakers. They have given us all the overview about clinical symptoms, pathophysiology, and how the CKM syndrome it goes. So my talk is about pharmacological management. So I'll be focusing more on drugs which are used in CKM syndrome. So I'll be talking with definition, then stages, core therapeutic classes which are used. Then we will see what is the major differences between SGLT2 inhibitor and GLP-1 agonist. Then therapy according to these stages and some take-home messages. So, cardiovascular kidney metabolic syndrome is a health disorder due to connections among heart disease, kidney disease, diabetes, and obesity leading to poor health outcomes. So, we have seen that one person is having multiple organ problems because of which there is connections between all these. So, the hormones and other important things which are released they affect all the organs because of which this syndrome arises. So these are the stages in short about CKM syndrome. I think Dr. Ehsan Sheikh and other speakers also delivered about this, that what are the stages. So stage 0 is where no risk factor is involved. And stage 1, where there is excess or dysfunctional adipose tissue which is present. So basically here obesity is the main component. And then stage 2, where there is metabolic risk factors and chronic kidney disease. So here we can say that the patient is suffering from hypertension or hypertriglyceridemia. Then there is metabolic syndrome and type 2 diabetes. Then stage 3 is subclinical CVD in CKM syndrome, where there is established cardiovascular disease and there is a little bit heart failure or there is ASCVD risk. Then stage 4 is clinical CVD is present. So patient is suffering with chronic heart disease or there is a stroke or there is arrhythmia. So there is a disease, then we call it as stage 4. So core management strategy involves lifestyle modification, weight management, in which the details are already talked about other speakers. So lifestyle modifications where healthy diet is involved, then regular physical activity, weight loss is the main component, then adequate sleep and hydration, and avoid other addictions like tobacco and alcohol. Then weight management is very crucial for improving the all risk factors, and these are various strategies which have been already discussed that how you can modify the weight. So pharmacological management as far as concerned is focuses on the therapies that provide multi-organ protection across the heart, kidney and metabolic symptoms. So we have to select a class of drugs which are acting on all these systems together, and some action on heart, some action on kidney, or some action on lipid profile as well as sugar. So we will be looking at some class of drug which has multimodal action. So this treatment of CKM syndrome is guided by American Heart Association staging framework, where it prioritizes early intervention to prevent progression to clinical cardiovascular disease. So we have to try that it should not progress to the clinical cardiovascular disease by starting early intervention. So pharmacological management as far as concerned is there are major therapeutic classes which are involved in management. Is first one is SGLT2 inhibitors, which involves empagliflozin, dapagliflozin, which is a cornerstone of CKM management regardless of diabetes status. So whether the patient is having diabetes or not, SGLT2 inhibitors remains the cornerstone. Then second class here is GLP-1 receptor agonist, which is semaglutide and liraglutide. Details already talked about Dr. Ajit Malik sir also. Essential patients with obesity or type 2 diabetes. So if the patient is suffering with diabetes and sugar abnormalities are there, then this is a main class which has to be used. Then other drugs which are coming up is non-steroidal mineralocorticoid receptor antagonists, which is we are well known about mineralocorticoid receptor antagonists, which are spironolactone or eprinone. So here we are talking about finerenone, which is a non-steroidal MRA antagonist, which is targeted for the patients with type 2 diabetes mellitus and chronic kidney disease to reduce the risk of kidney failure and heart failure events. Then other cornerstone is RAS system targets, for example, ACE inhibitor and angiotensin receptor blockers. These are standard therapies for hypertension and albuminic CKD. So wherever we are dealing with hypertension or there is albuminuria, then ACE inhibitor or ARBs becomes the choice of the drug. So we will see these classes one by one. First is SGLT2 inhibitor, sodium glucose co-transporter 2 inhibitors, which includes empagliflozin, dapagliflozin, canagliflozin. So they inhibit SGLT2 transporter, which is located in proximal convoluted tubule in kidney and which is responsible for 90% of the glucose absorption. So glucose absorption is inhibited because of which it induces glycosuria and natriuresis, and thus it lowers the blood glucose and reduces HbA1c levels. It also causes reduction in blood pressure because of osmotic diuresis and reducing arterial stiffness. Weight loss is also induced by this class of drugs because of activation of hypolysis and caloric loss. Then there is renal protection, which has been seen, and this is by the virtue of lower intraglomerular pressure. Then cardiovascular protection is also seen with this reduced oxidative stress. So we can see here that this class is has multimodal action. It acts almost all the systems which are involved in CKM syndrome. So this is again the mechanism of action. You can see here that there is SGLT2 transporter protein which is inhibited by this class of drugs, and the actions which are reduced after this is renal in glucose excretion, natriuresis, osmotic diuresis, hyperfiltration, and albuminuria is decreased, and there is systemic vasodilation, and thus there is decrease in the afterload production. And major adverse effect of this class is volume depletion or dehydration, because it is causing diuresis that may cause dehydration. And then one more important adverse effect is genital mycotic infection. Because of the glycosuria, there is risk of genital mycotic infection. So one has to be watchful while prescribing this class. And euglycemic ketoacidosis can be another adverse effect, and there can be bone fractures. So there are multiple trials which have been tried with these class of drugs to prove the efficacy and safety in the patients of heart failure and kidneys. So DAPA-HF is a well-known trial which includes dapagliflozin, which is first dedicated heart failure trial, which shows that dapagliflozin reduces the cardiovascular and worsening heart failure in patients with reduced ejection fraction. So include those without the diabetes. Then Emperor Reduced trial, which includes empagliflozin, they also shows benefits in heart failure patients by reducing the cardiovascular death and hospitalization and improve renal function. Then Credence with canagliflozin, it also demonstrated renal protection and cardiovascular benefits. Then DAPA-CKD with dapagliflozin, which shows that it significantly reduced kidney and CV outcomes in CKD patients, including those without diabetes. Then EMPA kidney is another famous study which includes empagliflozin, and it validated renal and CV benefits irrespective of diabetes. So we can see there are the multiple trials which have been conducted on this class of drugs, which proves its efficacy in patients whether they want renal protection on cardiovascular benefits or sugar control. So they have multimodal action. So current status of this class of drug is that they reduces heart attack, stroke, cardiovascular deaths, and heart failure hospitalization. And in kidney, they slow the progression of chronic kidney disease, delay dialysis. So they are effective across the entire heart failure spectrum and in CKD with or without diabetes. So if they are started early, they can give a better result in CKM syndrome. So these trials led to these drugs adopted in the guidelines for even diabetes, heart failure, and kidney disease management. So I will say that SGLT2 inhibitor remains the cornerstone for CKM management, regardless of the diabetes status. The next class, which is very important, we have is GLP-1 receptor agonist. So these include semaglutide, dulaglutide, liraglutide. So they mimic the action of endogenous GLP-1, which enhances the insulin secretion, inhibit glucagon release, delay gastric emptying, reduce food intake, and induce early satiety. So adverse effects seen with this class is gastrointestinal adverse effects, which is nausea, vomiting, diarrhea, and constipation. Then others are loss of appetite, fatigue, headache. And there can be serious issues sometimes like pancreatitis, gallbladder problems, and kidney damage. So these adverse effects are usually dose dependent and can lead to treatment discontinuation, though many are manageable with diet, hydration, and dose adjustment. So these class details are also talked by other speakers and how we have to give. But this remains very important drugs when we talk about CKM syndrome. So there are major cardiovascular outcome trials which have been conducted with this class of drugs. So leader with liraglutide, which shows significant reduction in MACE, which is major adverse cardiovascular event, in type 2 diabetes with established CVD. Then sustain 6 was with semaglutide, which showed that reduced MACE in type 2 diabetes with high CV risk. Then rewind is another study with dulaglutide, which also showed main reduction in broader type 2 diabetes population. And then Pioneer 6 with oral semaglutide demonstrated cardiovascular safety and outcome in type 2 diabetes. Then there is another obesity trial, which is a landmark trial, is STEP program with semaglutide 2.4 milligram, where the STEP trial showed unprecedented weight loss, which is around 15%. So it is very important drug in obesity. So whenever the patient is having obesity, then semaglutide is one of the important drugs. Then it gives cardiovascular protection. So there is established direct cardioprotective effect beyond the blood sugar control. Then weight loss revolution. So this semaglutide, which is Ozempic, and now we have tirzepatide, which is Monjaro. So they show significant weight loss comparable to surgery. Kidney benefits. This trial also indicated benefits for diabetic kidney disease, and so this trial also include these drugs, especially for the patient with existing cardiovascular disease or kidney issues. So this slide shows that SGLT2 inhibitor versus GLP-1 receptor agonist. So usually they have all the symptoms and they have multimodal actions. So they have actions. They decrease HbA1c levels. Both the drugs they decrease. Both the drugs they cause reduction in blood pressure. Both causes reduction in weight loss. Then lipid profile parameter is improved with SGLT2 inhibitor, while decrease in LDL and triglycerides are seen with GLP-1 agonist. Then there is decrease in non-fatal myocardial infarction and deaths from CV cause. Then there is decreased death from cardiovascular causes in heart failure hospitalization. Also, they reduces the risk of atrial fibrillation, which is less with GLP-1. Then they causes decrease in albuminuria and progression to end-stage kidney failure. And study shows that there is also improvement in liver steatosis and inflammation and fibrosis. So now MASH is also one of the component which is coming with CKM syndrome, where liver fibrosis is seen. So there also they have shown the effects. Then next class we have is non-steroidal mineralocorticoid receptor antagonist. So this drug is targeted for patients with type 2 diabetes and CKD to reduce the risk of kidney failure and heart failure events. They offer anti-inflammatory and anti-fibrotic benefits with a lower risk of hyperkalemia compared to older. So we know that we have spironolactone and epinephrine. So this is a non-steroidal drug. They block aldosterone effects on sodium retention and vascular remodeling. They are more selective than traditional agents like spironolactone, and they have less gynecomastia. So, finerenone demonstrated cardiovascular and renal protection in Fidelo DKD and Figaro DKD trial. So, this drug is approved for diabetic nephropathy. Then, well-known class of drug is RAS inhibitors, where we have ACE inhibitors and ARB. So, ACE inhibitors include enalapril, ramipril, lisinopril, perindopril, fosinopril, quinapril, tenderlopril, imidapryl, benzapril, and so on. So, they inhibit the angiotensin converting enzyme, preventing conversion of angiotensin 1 to angiotensin 2. It decreases vasoconstriction and aldosterone secretion, reducing systemic vascular resistance and sodium water retention. They increase bradykinin level, leading to vasodilation. So, indications and adverse effects of ACE inhibitors, they are indicated in hypertension and along with many comorbidities. So, whenever diabetes mellitus is present, ACE inhibitor becomes a choice. Prevent diabetic nephropathy. So, it decreases albuminuria. Then chronic kidney disease, this provide renal protection. Then heart failure with reduced ejection fraction and post myocardial infarction. It improves the ventricular remodeling as well as improves this survival. Common adverse effects with ACE inhibitors are dry cough due to bradykinin, then hyperkalemia, so you have to monitor potassium levels, then angioedema, rash, urticaria, dysgeusia, which is loss of taste, bad taste, then hypotension, especially after the first dose. And this class of drug is contraindicated in pregnancy because of fetal growth retardation and hypoplasia. Then we have angiotensin receptor blockers. So losartan, valsartan, candesartan, telmisartan, olmesartan, irbesartan are the drugs which blocks angiotensin 2 receptors, preventing vasoconstriction and aldosterone effect. No effect on bradykinin metabolism. So there is no cough, or we can say a very little amount of cough. Preferred alternatives for patient intolerant to ACE inhibitors. So those who are not able to tolerate, we can switch on ARBs. Indications are almost same as ACE inhibitors like hypertension, diabetes, CKD, and heart failure. And here common ADRs are similar profile but little mild like hyperkalemia, hypotension, and angioedema is rare here. Other important medications which you should keep in mind while dealing with CKM syndrome is lipid lowering therapy. So lipid lowering therapy itself is a big lecture. So there are a lot of drugs in the basket which can be used for hypolipidemia, and very important is statins. So statins remains the cornerstone for atherosclerotic risk reduction. So simvastatin, pravastatin, fluvastatin, atorvastatin, rosuvastatin, pitavastatin, mevastatin, lovastatin are the drugs. and it inhibits HMG-CoA reductase. So they cause reduced cholesterol by 20 to 50%. So they have high efficacy in reducing the cholesterol level. They also decrease LDL levels by 30 to 40%. And even plasma triglyceride levels are decreased by statins up to 10 to 30%. And increase in HDL is also seen 5 to 10% with statin. So adverse effect with statin is headache, nausea, bowel upset, rashes, sleep disturbance, and hepatotoxicity. So elevation of hepatic transaminase more than 3 times, and myopathy, which is important. So there is muscle tenderness and rise in CPK levels. So other class of drugs may be added to reach the LDL targets, which are given in the guidelines. So ezetimibe and new classes PCSK9 inhibitors, which include Alirocumab and Evolocumab may be added to reach the LDL targets. So, hypolipidemic therapy will be given according to the lipid levels or reports which the patient is having. Then, other emerging therapies which are coming up for the CKM syndrome, new classes of drugs are TR beta agonist, which is thyroid receptor beta agonist, which is resmetirom, which is recently approved for metabolic dysfunction associated steatohepatitis. So MASH is also coming up in a part of CKM syndrome where many patients they have liver dysfunction. So their new drugs are coming. Then triple receptor agonists. So we have GLP-1 agonist. Then we have tirzepatide, which is a twin creatine, which blocks two receptors. And now we have triple receptor agonist, which is GLP-1, GIP, and glucagon agonist. So this is retatrutide, which is trial is going on for their effects in cardiovascular and kidney diseases. Then there are lots of RNA-based therapies for lipoproteins, which is olpasiran and zilebesiran. So these are also a new class of drug. Again, the trials are going on to see the efficacy of these drugs. Then we have aldosterone synthase inhibitor, which is lorendrostat and vicadrostat, and then many anti-fibrotic therapies for MASLD. So as I've said that now the fatty liver or MASH is an important component of cardiovascular disease. Many patients with obesity, they have this liver dysfunction. So anti-fibrotic therapies are coming up for this. So obeticholic acid, then Senicriviroc and Simtuzumab. So these are the drugs which where trials are going on, and maybe in future they will be there in the market for the treatment of CKM syndrome. So now these are the cornerstone drugs which are used in CKM syndrome. So management by stages. So as we have discussed that stage 1 is adiposity as a major component. So where fat so focuses on weight management should be there. So lifestyle changes are insufficient, and anti-obesity medication like semaglutide or tirzepatide may be initiated, which gives around 15%, 10 to 15% weight loss, which is very significant. So these drugs can be tried in stage 1. Then stage 2, where there is metabolic risk factors and CKD. So target treatment of risk factors like hypertension, hypertriglyceridemia, and diabetes should be there. And then cardioprotective therapies like SGLT2 and GLP-1 agonist can be introduced to prevent the further evolution of cardiovascular disease. Then stage 3, where there is subclinical cardiovascular disease. So intensified therapies for those with subclinical atherosclerosis or elevated cardiac biomarkers, which is pro-BNP. So then other therapies should be treated. These conditions should be treated little aggressively. Lipid profile should be controlled. Sugar should be controlled, and other class of drugs should be initiated. And stage 4, where clinical cardiovascular disease is established, there should be full implementation of guideline-directed medical therapy for established heart failure or atherosclerosis disease. So the patient is, if he is having heart failure, then drugs like ERNI, which is angiotensin neprilysin inhibitor, and atherosclerosis disease. So you have to target the lipid levels. So full aggressive treatment should be done. So this is a current CKM paradigm of care. So you can see here that these are the usually diseases which are present along with the CKD. So if there is hypertension, patient is suffering from hypertension, then lifestyle change remains the cornerstone of all the abnormalities, whether it is metabolic abnormality or some other. And then there should be weight loss, and ACE and ARB should be given to control the hypertension, and other drugs which are involved in management of hypertension can be used. Then patient is having hyperlipidemia, then lifestyle changes and weight loss should be initiated. Then for hyperlipidemia, statins and other drugs like fibrates, and then ezetimibe and new class, which I've already discussed, that PCSK9 inhibitors, and icosapentaneal ethyl should be given to control the hyperlipidemia, and targets should be achieved according to the guidelines. Then if your patient is suffering from heart failure, then ACE and ARB and ERNI, which is angiotensin receptor, neprilysin inhibitor, which is sacubitril valsartan combination, then beta blocker, SGLT2 inhibitor, spironolactone and eprinone. So heart failure therapy should be initiated. If the patient is having overweight or obesity, then apart from lifestyle change and weight loss, there should be consideration of weight loss therapies, drugs like GLP-1 agonist, which is semaglutide, and other which is there in the market with the name of Monzaro, which is tirzepatide, can be used. Then the patient is having type 2 diabetes mellitus, then SGLT2 inhibitor, which has shown good results on blood sugar and HbA1c levels, and also GLP-1 receptor agonist. Then for chronic kidney disease, ACE and ARB because of reduction in the albuminuria. Then SGLT2 inhibitors which show kidney protection. And in diabetic CKD, if the patient is suffering from sugar as well as kidney dysfunction, then GLP-1 agonists are a good drug, and then mineralocorticoid antagonist, which is finerenone. And if the patient is having CVD risk, atherosclerosis, CVD, cardiovascular disease, then apart from lifestyle change and weight loss, there should be smoking cessation, then statins and PCSK9 to control the lipids, ACE and ARB to control the hypertension as well as survival benefits, then SGLT2 inhibitors for cardioprotection as well as renal protection, and GLP-1 receptor antagonist. So here we can see that almost all the metabolic abnormalities, whether it is hyperlipidemia or heart failure, SGLT2 inhibitor and GLP-1 receptor antagonist remains the cornerstone for the management of CKM syndrome. So if the patient is suffering from cardiovascular, kidney and metabolic, all the parameters, these drugs should be initiated. So these are the important drugs and classes. So there is a lot of other drugs which are used in various metabolic syndromes. So important message here is that CKM syndrome treatment is personalized. So what your patient is suffering from, you have to see that and aim to prevent the progression by addressing the interconnected heart, kidney, and metabolic issues through a combination of lifestyle change, targeted medication, and coordinated special care. So with this, I will conclude. Thank you so much for giving me this time. Over to Dr. Zubair.
Thank you, ma'am. Indeed, being a pharmacologist, yeah, it was a very difficult task to cover all the three in-depth diseases, cardiac and then metabolic. And I believe, and even the delegates will definitely agree that you have done justice to that. Thank you very much. For our next, I now call upon to understand the role of kidney in CKM syndrome. I call upon Dr. Sachin Soni sir, Head of Nephrology, Dialysis and Kidney Transplant Center at Medicover Hospital, Chhatrapati Sambhajinagar, with his experience of more than 15 years of providing service in all the kidney related conditions, including transplant and other interventions. I request sir to kindly share your screen. You can start your talk.
Afternoon. I think I should be audible now.
Yes, sir, you are audible now, and your slides
Yes.
are also visible.
Yes. So I will go ahead with my presentation. I generally like to talk on clinical topics, but this time I got the opportunity to talk slightly theoretical topic, which is related to more of pathophysiology and role of kidney in CKM syndrome. Till now, all the speakers have almost covered many aspects of the things which I am going to speak. Still, I would like to offer kidney a center stage in this talk, which is anyhow expected from this particular lecture. So, wha- uh, by now we have known that what is CKM syndrome is a paradigm shift related to how we understand chronic diseases. So now it is a combination of cardiovascular disease, kidney dysfunction, and is a combination of metabolic disorder. And increasingly being understood that these are not distinct entities, but quite frequently they are interrelated and they kind of aggravate each other's situation, and fixing one may help fixing another also. So that is how this entire understanding is evolving related to CKM syndrome. Also looking at some pharmacological aspect, which was very well covered by previous speaker, where a similar drug or single drug can be useful in managing all the three syndromes. So that's how it is. So cardiovascular could be like ischemic heart disease or cardiac failure, anemia, hypertension. They all are like, it is not only ischemic heart disease which we are looking at, but entire spectrum. Kidney also acute diseases, chronic diseases, or worsening kidney diseases, and metabolic disorders. So it could be insulin resistance, dyslipidemia, obesity, hyperuricemia, diabetes, all these metabolic conditions, and they all influence each other. So, as the topic is, we are going to now focus upon kidney and why kidney matters in systemic health. So, as per our existing understanding, it is a focus of filtration. So, it removes waste products, toxins from the bloodstream, and maintains homeostasis for all organs. It is also critical in blood pressure control because it helps in regulating fluid balance, also helps in controlling the vascular tone through multiple hormonal pathways. It has a role in making certain hormones which have indirect role in managing cardiovascular conditions, and it also helps in metabolic regulation. So by virtue of various pathways, uh, the kidney plays a central role uh, in in body homeostasis per se. So what we are going to look at is we are going to look at kidney function fundamentals, then pathophysiological mechanism, which can where kidney takes a center stage. How does clinical disease progression, uh, that is from early CKD to worsening CKD, interacts with other organs, uh, diagnostic approaches, and I think I'm not going to talk about treatment and innovations because previous speaker has already covered this topic in detail. So traditionally, we have been understanding that uh, kidney is a simple filtration organ, and entire focus is centered at urine production and basic electrolyte or acid base balance. But now current recognition is that kidney is a is a complex regulatory structure. Sorry, what happened to my slides? So it's a complex regulatory central, and it has a central role in cardiovascular as well as bone health, bone blood production, and metabolic homeostasis. So apart from filtration function, we have discussed that kidney is a powerhouse of hormones. It produces erythropoietin, which stimulates red blood production. Renin, which is the initiator of RAS cascade. It helps in conversion of inactive vitamin D to active vitamin D, and it is also center of prostaglandins along with other organs, which modulates blood flow and responds to inflammation. So, by virtue of this various multi-system regulatory function like hemodynamic control, mineral homeostasis, hematological control, as well as acid-base control, it helps in homeostasis of entire body, and its function is not merely related to kidney function. So, in this vicious cycle of CKM, that is kidney disease, cardiovascular, and metabolic disorders, um, if we think kidney as a starting point where there is a reduction in filtration, it leads to accumulation of toxin, and of course, it leads to hormonal dysregulation, which in turn leads to hypertension, increased cardiac overload, cardiac remodeling, increased cardiac workload. See, kidney disease per se leads to dyslipidemia, insulin resistance, activation of inflammatory pathway, increase of oxidative stress, and all these vicious cycle continue. So it is a self-reinforcing cycle, and that suggests because these organs are not separate, these systems are not separate, they are all interconnected. So dysfunction in one affect this leads to dysfunction in another. So these are the conventional risk factors for development of cardiac disease. In addition, kidney disease leads to some unique risk factors, which we are going to see in subsequent slides. So we are all well versed with CKD stages, stage 1, 2, 3, 4, and 5. So as the disease progresses, there is a drop in renal function, and it is particularly pertaining to stage 3, where cardiovascular dysfunction starts. So we are going to look at cardiovascular complications. So one factor which kidney disease affect is accelerates atherosclerotic mechanism, and that is by virtue of increase in oxidative stress, elevated inflammatory levels, and which can happen in any chronic inflammatory condition. Also happens in chronic kidney disease. But more importantly, chronic kidney disease by itself is a risk factor for development of vascular calcification because of various mineral bone related dysregulations. So patients with CKD experience atherosclerosis progression 2 to 3 times faster compared to general population, and this explains dramatically elevated cardiovascular mortality rates in patients with chronic kidney disease. And we also know that CKD patients have severe hypertension. They are refractory to therapy, and this hypertension, resistant hypertension, or episodes of accelerated hypertension due to chronic kidney disease leads to increased cardiac workload. Because of chronic kidney disease, there is the increased sodium and water retention, so there is increased fluid overload and plus neurohumoral activation. So all these factors combine to increase workload over heart, which leads to left ventricular hypertrophy, and this results in progressive cardiac worsening, reduced chamber volume. It impairs diastolic filling and increases oxygen demand, which is the perfect situation for worsening heart failure. So, kidney, by virtue of various mechanisms, by virtue of anemia, hypertension, by virtue of volume overload, activation of renin-angiotensin system, as well as sympathetic system, leads to increased workload over heart, and which perpetuates in development of heart failure. In addition, certain situations like electrolyte disturbances, we all know hyperkalemia per se is arrhythmogenic and it can lead to sudden cardiac arrest. Hypocalcemia can create unstable cardiac electrical activity, can trigger arrhythmias, autonomic dysfunction, which can be because of uremia, uremic toxins, or because of the condition which are causing chronic kidney disease. That leads to altered response from heart. It changes heart rate variability and increase increases susceptibility to sudden cardiac death. Coronary artery disease, again, CKD by itself is a risk factor for ischemic heart disease or coronary artery disease. In fact, the most frequent cause of death in patients with CKD is ischemic heart disease. And then we have also spoken about left ventricular hypertrophy, fibrosis, and arrhythmogenic potential of kidney. Central to all this pathogenesis lies the activation of renin-angiotensin aldosterone system. So this is like we have been studying this over years, probably from first MBBS now, how the renin-angiotensin aldosterone system activation happens. So renal hypoperfusion stimulates renin release, converted to angiotensin. Then it leads to aldosterone secretion, and subsequently it causes vasoconstriction, sodium retention, and activation of inflammation. So I think part of this we have already discussed. So multiple mechanisms why which hypertension becomes resistant in patients with kidney disease is by virtue of activation of renin-angiotensin aldosterone system, increased vasoconstriction, sympathetic activation, again central to kidney disease, and then sodium retention. And that's why quite frequently in management of hypertension in such patients, we try to target all these arms. Like we try to target vasoconstriction by giving vasodilators like uh, calcium channel blockers. Then we use we try to utilize RAS blockade plus beta blockade, which also has effect on renin-angiotensin aldosterone system. Patients developing sodium retention, we try to handle them with diuretics. And because the hypertension in these patients is multifactorial, we need multiple agents to handle this kind of situation. In addition to hypertension, there are certain metabolic dysfunctions like accumulation of uremic toxins interferes with insulin, and it can lead to impaired glucose uptake as well as insulin resistance. Vitamin D deficiency can also lead to impaired beta cell function, and which again contributes to insulin resistance. Chronic inflammation also contributes, and adipokine dysregulation. These are various factors by which even insulin resistance is potentiated by development of chronic kidney disease. So, and this leads to homeostasis disruption. So, initially, stages leads to insulin resistance, and over the period of time, we know that patients with diabetes are at increased risk of development of hypoglycemia if they are suffering from chronic kidney disease. Plus, these are certain specific abnormalities, lipid abnormalities, which are associated with CKD. So there is elevated cholesterol. Even the proteinuric patient, normal renal function is also associated with higher level of cholesterol, higher level of triglyceride, lower HDL. So all these, this is the basically atherogenic lipid profile, which potentiates atherosclerosis also. Mineral and bone disorders. Earlier, this was known as renal osteodystrophy, and now the current term used for this situation is CKD MBD. And there are various CKD MBD features. So, most important of that is a phosphate retention. So, as kidney function worsens, it leads to retention of phosphate, and that leads to hyperphosphatemia. Even if there is a dietary restriction of proteins, phosphate keeps getting accumulated in CKD patients. Calcium dysregulation. So that is by virtue of impaired absorption as well as impaired conversion to active vitamin D. So that also affects hypocalcemia, hyperphosphatemia, and when this develops, it stimulates parathyroid hormone, and parathyroid hormone, when stimulated, there is development of hyperparathyroidism, what we call as secondary hyperparathyroidism, and this potentiates development of vascular calcification, and that is a unique risk factors in patients with chronic kidney disease. So phosphate rises, calcium for stimulates PTH secretion, and that leads to even to bone resorption. There is increased risk of fractures, bone pain, as well as vascular calcification. which is a deadly complication of advanced CKD. So these are some of the stages of how calcification develops. So in presence of endothelial injury, which is again uremic toxin can be an initiator of this endothelial injury, along with the inflammation that damages vascular endothelium. After damage of vascular endothelium, there can be increased deposition of calcium phosphate product. There can be a precipitation of these elements over the damaged endothelium, which leads to arterial stiffening and vascular calcification again become risk factors. Then we have also spoken inflammation. We have repeatedly said these are some of the mechanisms by how which inflammation develops. So CKD patients, it is sometimes tricky to interpret CRP in CKD patient because their baseline CRP is elevated. They are associated with 3 times increased risk of cytokines, which are pro-inflammatory, and there is always associated endothelial dysfunction nearly in 60% of CKD population. And all of these factors combine to various dysregulations. I think it will be too theoretical to talk about these molecules, but all sufficient for us to understand that increased release of cytokines, increased release of inflammatory products affects our body in multiple negative ways. It also potentiates accelerated aging system. So these patients, like they develop signs of premature aging. CKD by itself increases oxidative stress by virtue of mitochondrial dysfunction, increased release of NADPH oxidase, and again we have spoken about inflammatory cells. So cumulative oxidative burdens overwhelms our body defense mechanism and subsequently potentiates like all this cascade of CKM. And quite frequently, it is a diagnostic challenge to have to know CKM syndrome because quite frequently there is a subtle presentation. Clinical signs are non-specific. There is a clustering of risk factors. Quite like many of these risk factors are common to all these conditions, and many times it is detected incidentally. Even there is no single laboratory test which can kind of tell us what regarding diagnosis of CKM syndrome. So it is multi integration of multiple tests. Important of them, of course, is the serum creatinine, and from nephrology perspective, urine analysis and proteinuria estimation. More there is more stress on ACR, that is albumin creatine ratio detection, because it is an important marker of onset of kidney disease, as well as it is a marker of endothelial dysfunction. All other tests we have already spoken about, like lipid profile, HbA1c glucose, Dr. Ehsan spoke about. Then HSCRP, as I said, it can be a confusing marker in patients of chronic kidney disease. NT-proBNP, which lets us know about failing heart, and PTH we have just talked about. So it is always integration and combination of various tests which we use for detection. So as the program itself is structured in a way uh, that CKM syndrome needed multiple doctors to talk about it. And that's what we are seeing. Like we have cardiologists, endocrinologists spoke about it. Then nephrologist I'm speaking just some time back, pharmacologist spoke about it. And that in itself is suggestive that this syndrome like this needs a multidisciplinary team approach because each component and each person, each individual, each team member has an important role in managing it. It is a complex syndrome, emerging syndrome, and as the time passes by, I think we are likely to understand more about this syndrome. And more importantly, as the therapies keep evolving, I think the aim would be to utilize minimal medicine or utilize medicines which acts on all arms of CKM syndrome, like SGLT2 inhibitors. There can be GLP-1 agonists or even RAS blockers, as was discussed in previous talk, which can provide protective effect from all these conditions. I think that's all I have to talk now. Thank you so much for your patient listening. Thank you to the organizer, Elite Education Society, for this chance for me to learn also about the CKM syndrome, learn pathophysiology quite frequently in our clinical practice. We don't get into molecular levels, but opportunities like this help me read about the topic and share my experience with you. Thank you so much.
Thank you very much, sir. And indeed, listening to you was a very great experience for all the delegates. Uh, our MMC observer, Dr. Swapnil sir, is online. I request the president of Elite Education and Welfare Society to kindly present the memento and call to start virtually. And I request sir enlighten us with words. Sir will present memento. Sir, this will you very soon as we meet.
Sir, you are most welcome for our webinar. No, can you hear me, sir? Please. Okay, sir.
Ah,
Yes.
Good afternoon, everyone. Respected Dias, Dr. Shafi sir, and all the speakers. As a MMC observer, I convey my best wishes for this very nice academic
म्यूट करो
fest
कंप्लीट करो
organized by uh, Gur Medical College, Badnapur. I have been attending this webinar since morning, and all the speakers have presented very nicely all the topics. And definitely, this webinar is going to update and value to our day-to-day practice. Once again, best wishes for this webinar from MMC and myself. Thank you.
Thank you very much, sir, for your kind words and for your support also. Thank you for joining us. Now we'll move on to next session.
Moving to our next session, our speaker is an interventional radiologist, Dr. Salman Mapare sir. He is currently attached to Icon Super Specialty Hospital and Tooth Hospital in Chhatrapati Sambhajinagar. Salman sir is a graduate from Sir JJ Group of Hospital, Grand Medical College. He has done his MD from Science and Interventional Radiology from KEM. Sir is has also got a European Board certificate for CIRSE from Austria. Uh, Sir will be talking on role of interventional radiology in imaging and complications of CKM syndrome. So I request sir to kindly unmute himself and share the screen, and you
Yes,
can
sir.
take over.
Yes. Okay, sir. Am I audible, sir?
Yes, you are audible.
Please share the screen. Okay. Uh, Good afternoon, everyone. As we are seeing in mornings, that CKM syndrome, the pathophysiology, the medical management has been spoken up in a very detailed by the previous speaker in a very beautiful way. So now the role of IR in the management of the complications, which usually happen in the CKM syndrome as a continuum. So IR stands in a way in a management as a palliation, as a definitive treatment. So as discussed previously also, There are these five stages of CKM. So uh, so the complications which happen due to the CKM are due to the endothelial dysfunction, which leads to atherosclerotic complications, thrombotic complications. Then due to CKD, there are hypertensive complications, and due to CKD, the patient underwent a fistula for the dialysis, and that dialysis complications will also be included. And thus, this IR will help in managing in terms of imaging and then in terms of the palliation and therapeutic treatment. So various tools which as a IR we use for this diagnosis are ultrasound and CT guidance, followed by the angioplasty, stenting, and thrombectomies for the thrombosis and embolization wherever required. So these IR procedures will definitely help to reduce the post-procedural trauma. That way, it will reduce the complications associated with the diabetes and hypertension. These are the short-term procedures and faster recovery. So these are the various components where IR will aid. So one of them is like the cardiovascular thing, in where peripheral arterial diseases, due to critical limb ischemia and acute thrombosis of the vessels. Then in renal, we have a renal artery angioplasty and stentings and dialysis access salvage. For metabolic and obesity, there is a upcoming thing which is a bariatric embolization. And for the complications associated with it, like a thrombotic occlusion of the arteries, veins, and the stroke. So I will be presenting a case-based discussion in further slides. So let's get started. This is the first case of a 55-year-old gentleman with uncontrolled diabetes and hypertension on two anti-hypertensive drugs. So he's having a non-healing ulcer over the foot. It's over the lateral aspect of the foot. So going to the angiosome theory of the foot. So ulcer was on the plantar aspect, and his angiography was done, which will demonstrate the blockage of the anterior and posterior tibial arteries. Since the ulcer is on the lateral aspect of foot, so going through angiosome theory, we decided to go for the posterior tibial artery treatment. You can see we underwent a posterior tibial artery angioplasty. This post angioplasty DSA is demonstrating opening up of this vessel and formation of the foot arch. And this is the post procedure 1 month follow up showing the biphasic waveform in the vessel and healing of the ulcer. Yes. Is this another case of the 60-year-old gentleman with uncontrolled diabetes and hypertension? He's a smoker and he's having a gluteal pain and thigh claudications. So on imaging, he was diagnosed to have a common iliac artery occlusion on the right side. So the patient was underwent CT scan and angiography, followed by the complete stenting of this occluded segment, as we can see over here, the complete occlusion of this vessel. So due to that, the patient was developing claudication, chest pain, and gluteal claudication. Further DSA angiogram showing the complete occluded segment in a common iliac artery up to the external iliac artery. So we underdo the angioplasty and then further the stenting. So this is a pre-stenting image and the post-stenting image. This helps in resolution of the symptoms of patient, that way aiding his further management. This is another case of 42-year-old female patient on the antihypertensive drug. She is also having uncontrolled diabetes and hypertension, and she developed the infrarenal aorta thrombosis as well as left renal artery stenosis. So, and we underwent with the angiogram from the brachial artery route since the infrarenal aorta is thrombosed. As you can see here in angiogram, there is occlusion of the infrarenal aorta and there is a severe stenosis of the left renal artery at the origin. So here is the image depicting the angioplasty of that segment, and this is the post-angioplasty angiogram run, where you can see that the stenosis has been resolved, the gradient has been resolved, and the patient's hypertension was controlled. There is a another case in which a 36-year-old female is on CKD with hemodialysis fistula came with sudden loss of the thrill at the fistula site. Ultrasound reveals the thrombosis of the fistula site and juxtaanastomosis vein. So she was taken with further for fistulogram and the plasty. So the fistulogram from the arterial side. Okay, this is a brachiocephalic fistula. As you can see, the venous side is not at all opacified and just anastomosis side. So this fistula has been accessed through the venous side, and the venoplasty is done along entire segment. In the post venoplasty venogram showing the complete opening of the fistula and resolution of the complaints of the patient. So here is the angiogram showing the occlusion of fistula. This is a final angiogram showing the opening of the fistula. This is the Doppler image at the end of 1 month showing the beautifully depicting the thrill and the resolution of the thrombosis. This is another case. So the renal tumors and cysts, these are most commonly associated with this incidental noted findings in the patients of the renal diseases. So this I am presenting this case here because when we choose for the operative management of these tumors, so most of the time they'll end up in a complication of the post anesthesia and post surgery. Even the blood loss is also there. So when the tumor as in are in a criteria where we can do a minimal invasive options for them, just like this one case where this tumor was less than 5 centimeter, and he is a perfect candidate for the ablation therapy, which will help him reduce his hospital stay as well as reduce the blood loss and complications associated with the management. As we can see, this tumor has been completely ablated with the radiofrequency ablation probe, and this CT scan is a 1 month follow-up showing complete disappearance of tumor and cure of the renal tumor. So now coming to the thrombotic complication of the CKM syndrome. So is another case with a treated female who is having uncontrolled diabetes mellitus and AKI, and there was sudden acute right lower limb swelling. It was red, tender, and having increased pain, which suggests the development of the post-thrombotic syndrome. PTS is a indication for the thrombectomy, and yes, they underwent with the ultrasound, which depict the complete common femoral vein and iliofemoral DVT. So this patient of underwent thrombolysis with IVC filter placement. As you can see, we have placed IVC filter from the jugular access. The filter has been placed below the left renal vein, and this is the popliteal vein access showing the complete DVT from the iliofemoral aspect. As you can see, we have crossed the vein, and after post suction, this is the images. This is a final venogram which is showing the resolution of the DVT, and this is a 1 month follow-up showing the complete resolution of DVT and compressibility of the vein. This another arterial thrombus case, which is arterial thrombotic complication of the CKM, in which this patient is having a left hand second to fifth digit acute digit ischemic pain with developing gangrene at the tip of the second digit, as well as patient is having dizziness and vertigo. So further evaluation of ultrasound suggests there is a development of the subclavian steel with reversal of flow in the left vertebral artery and further monophasic flow in the runoff vessels along brachial, radial, and ulnar artery. There is occlusion of the left subclavian artery over the origin. So we underwent with the CT scan and followed by this DSA angiogram, where we can see the angiogram is taken from the right vertebral artery, and you can see there is a filling up of the vertebral artery, and followed by the further filling of the brachial artery and axillary artery, and complete occlusion of the axillary artery, subclavian artery. Sorry, as you can see here, there is subclavian still happening over here. So this case underwent further uh, thrombectomy and stenting of the occluded segment. Is a pre-procedure hand image of this patient. Here is subclavian still demonstrated by angiogram from the right vertebral artery. Here is again right vertebral artery, left vertebral artery, brachial artery, axillary artery, ulnar artery. Here is the occlusion. This segment, the post thrombotic. Here we have crossed the occlusion segment. The thrombectomy has been done. As you can see, there is still residual narrowing in the cleven artery in a second and third segment. Yeah, sorry. You can see this is, sorry, this is post-stenting angiogram, which is depicting the antegrade flow from the occluded segment. And this is again the right vertebral angiogram, which is the now show no filling of the left vertebral artery. That means resolution of the still. This is a 1-month follow-up image of this patient's hand, where the residual gangrene is still there at the tip, while the other digits have not developed any gangrene and has been seved off. There is another complication of the CKM syndrome in which this patient has developed a left-sided recurrent TIA stroke, which on further angiogram reveals there is a 95% critical stenosis at the left ICL. As you can see in this MRI image, there is acute infarct developing at the periorrheic region on the left side and at the posterior part of this occipital region. There is chronic area of gliosis as well, suggesting recurrent TIA. He underwent Doppler and CT angiogram, revealing the severe critical stenosis at the common carotid artery, approx 95%. Here is a DSA angiogram image depicting the severe stenosis. So this patient underwent ICA stenting. So DSA angiogram depicting the severe stenosis at the left CCA. This is a brain angiogram of the same ICA segment, depicting no occlusion from the ACA and MCA segments. This is the angioguard device used to prevent a distal embolus. This is the stent deployment. This is the post angioplasty of this segment, and this is the last DSA image depicting resolution of the stenosis. This is the embolic potato device depicting the capture of the embolus which has traveled distally while performing the procedure. So now have we come to the end of this vascular intervention impacting thing. So now uh, we have addressed about thrombotic complications as well as the renal complications of the CKM syndrome. So this is a multimodality approach is commonly depicted in the CKM syndrome, as we previously seen that medical management as well as diabetologist, nephrologist, cardiologist, all interventions are required in this case to completely do a holistic approach to this patient, targeting the interconnected organs. Now, this is the novel thing which is coming up in a great way is a bariatric embolization of the left gastric artery for a morbid obese patient. So the whole previous surgeries which used to perform for the morbid obesities were the Roux-en-Y gastric bypass, gastric bending, sleeve gastrectomy. The whole idea was to target the fundic region of the stomach where there is a secretion of these ghrelin hormones and the leptin cycle. So what has been done in terms of this is a trial showing the embolization of these fundic vessels. So left gastric artery, the terminal vessels have been embolized through the multiple PVA particles. And as we can see here is a representative image, the pre-angiogram showing multiple hypervascularity in the fundic region. While in the post-angiogram, there's complete loss of the vascularity of the fundic region, while the peripheral branches are preserved. This will ensure the no ischemic damage happen to the fundic region of the stomach. So this trial has been done with the RSNA and the JASC journals, and it depict there is a significant weight loss with a BMI from pre-procedure to post-procedure around 17 to 4.5%. While the trial is still going on, the side effects of this embolization being non-target embolization into the left hepatic artery if it is arising from the gastric artery and ischemic necrosis of the fundic region of the stomach. So in conclusion, it is a minimal invasive solution for the managing cardiovascular, kidney, metabolic, and thrombotic complications associated with this syndrome. And with the precise safety and efficacy of the patient, the IR will definitely help up in covering up this palliation and as well as therapeutic management of this CKM syndrome. And thank you to the Shafi sir and all the organizing committee for allowing me to present this presentation. Thank you for this. If you have any questions, please feel free to ask.
Thank you very much, Salman sir. Uh, the material that you have shown, it shows that you are already prepared for the CKM, and your work is really novel work, and all the slides and all these things, the collection of data, it is really remarkable,
Thank you so
and everything that you have covered. Thank you very much, sir, for giving your
thank you so much, sir.
such a precious time. Thank you, sir. So, with this, we came to the conclusion of our webinar. I would like to request our President, Dr. Mohammed Shafi, sir, to give the concluding remarks and vote.
So thank you very much, all the delegates, for joining today's webinar. I hope that this webinar was useful for you, and I'm very thankful to all the our speakers, Dr. Yogesh Lakas sir, Dr. Sohail Nurani sir, Dr. Ehsan Sheikh sir, Dr. Abhijit Bhale sir, Dr. Shruti Chandra madam, Dr. Salman Mapara sir, Dr. Sachin Soni sir, Dr. Sachin Sodanke could not make it today, so that is not a problem for us. But all the speakers, they have done a great job, and I am very happy that most of the delegates, those who have registered for this webinar, they have joined also, they have enjoyed also. Dr. Swapnil Mantri from Partur, he was appointed as the Maharashtra Medical Council observer for this webinar. He was continuously watching, and he has said few words about this webinar also. So I am very thankful to Dr. Swapnil Mantri sir, and I am very thankful to all the speakers. They have taken a lot of efforts to make this webinar successful. I am also very thankful to all the delegates, those who have registered and those who have stayed till the last of this webinar. Elite Education and Welfare Society is a registered society in Chhatrapati Sambhajinagar, and we are doing our CPD program and online webinars regularly. This year we started with today's CKM syndrome webinar, and in this year also we will plan around 4 to 5 webinars also, and we will also plan CPDs also. So I request all of you, please be there in the group, Elite Education and Welfare Society group. It's an admin control group, so you will not get unnecessary messages, but you will get the messages regarding the forthcoming webinars and the CPDs. So please don't leave the group, and you can ask your friends also, those who are interested to attend such webinars and those who are interested to earn Maharashtra Medical Council credit points also. So there are many people in Maharashtra, those who are in need of credit points. This Elite Education and Welfare Society is started to conduct such webinars and such CPDs, so that the all medical fraternity benefit from this type of webinars and CPD programs which are accredited by Maharashtra Medical Council. So very soon we are going to apply to Maharashtra Medical Council for accreditation of our academy for conducting webinars independently. So that will be done in future. So I request all of you, please pass this message to your friends also, that there is Elite Education and Welfare Society who is conducting the webinars and CPDs regularly. So that you can register and enjoy such type of activities. So I am very thankful to all the delegates for joining this. Please don't leave the group. Now we will take the attendance also, and within 3 days you will receive the certificate. E-certificate will be given to all registered participants. If anyone has not submitted the Google form, please fill and submit it, because we get your information, your name, your registration number through the Google form only. If you have paid the fee but you have not submitted Google form, your name will not come to us. So please make sure that you all of you please fill the Google form so that we get your name, number, and we'll post the number of delegates who have registered for this webinar. The list will be posted in the group. You can check your name. You can revert back to us if you have any problem. Within 3 days, we will give you the certificate, and within 15 to 20 days after we submit the documents to Maharashtra Medical Council, your credit points will be deposited to your registration number. So you can check it after 20 days from today. Don't worry. In last 3 years, we have conducted almost 9 to 10 webinars, and all the delegates, they got the certificates. So certificate also and credit points also. So need not worry about the points. You can write to us. You can write to Maharashtra Medical Council. And no need to message also. Just check the list which we'll post in the group. List will be the names which are uploaded to the Maharashtra Medical Council website. We have to upload the names, we have to pay their fees, and submit all these documents which are signed by the MMC observer. So all these are the procedures we need to follow after the webinar is over. So a little bit have a patience at least for 15 to 20 days to get the credit points. So once again, I thank you all for joining this webinar. I hope that in future also you will join and register with us. Thank you very much.
Thank you, Shafi sir. So the procedure for points, as sir has already explained, at first a list will be published into the group. Please check your names, your registration numbers, if it is there into the group. If it is not there, you can communicate the three members that are given the numbers, me, Dr. Zubair Fauzi, then Dr. Mohammed Shafi sir and Dr. Jawad sir. We see the person who look after all these registration and all. Okay. If you have any problem, you should tell us within 24 hours the published list. Because after that, we will publish, submit the list to the MNs. Okay, so if you communicate with us after 2 to 3 days of list published, so already we will be publishing that to MMC. So then you will miss the points. Okay. So list will be published, then we will go to it will be we will wait for 24 hours, then we will submit the list to MMC. After that, then the signatures, other formalities from the observer and all will be done. Then they will go to MMC, and after 15 days of receiving by the MMC, they will credit the points to you. Okay, so we will proceed with the final procedure of attendance. So please keep your cameras on and keep your smiling faces on the screen. Okay, I request all the delegates to kindly keep their cameras. One thing that you will get your e-certificates via link. So you will have to download your e-certificate. That after the submission of the documents to MNs. Okay. So on the permission of our president, I call this webinar to be closed. Thank you everyone. Thank you very much.
Thank you, sir.